Good morning, everyone. Welcome back to part two. The only thing I'd like to say is that I hope most of you were able to attend yesterday either the SWOG seminar or the main GU when we talked about the SWOG seminar as well as the Scholars Program. The thing I failed to do is to put out the little flyers that you see in front of you, which are our opportunities to honor Nick by contributing to the fund at the Hope Foundation. I love QR codes. You just flip it over in the back and tap it and just touch on the code and you can make a contribution. I would encourage you to think about doing so. We're reinvesting in basically ourselves. And as Joe Horn pointed out during the committee chairs meeting just a moment ago, that if you go to the Hope Foundation website, there is a litany. I mean, almost everyone can apply for funding for almost anything. Tom Flagg was talking about having, a program where we can develop videos on how to educate new CRAs, which is a brilliant idea. And so Tom's going to go off with develop a concept. We'll ask the Hope Foundation to enable us to do that, and we'll go forward. So seriously, think about if it's within your capabilities to make a gift to the SWOG Fund. We're honoring Nick because of all the things that he did for us. Without further ado.
I don't know if this is working. Hello? Hi. Good morning, everyone. We'll go ahead and get started. We are going to flip the sequence a little bit, and we'll start with kidney cancer sessions. Both advanced renal as well as localized renal. Brian Schuck, my colleague, cannot be here, so I'll be presenting and moderating throughout. I'm Olka Vaishampayan from University of Michigan. We are going to start our presentation actually with our probe video that we've made for educating patients, providers, CRAs, etc. about this study. And then we'll go on to our usual presentations. Go ahead.
Hello, I'm Peggy Zuckerman. I was diagnosed with metastatic kidney cancer in 2004. If you have kidney cancer that has spread beyond the kidney to other places in your body, you may have the option to get treatment in a clinical trial called S1931. Clinical trials are research studies that involve people. They're how doctors find better ways of treating cancer. Doctors created the S1931 trial to answer an important question about treating advanced kidney cancer. They want to learn if patients who receive immunotherapy also benefit from having surgery to remove their kidney tumor. And while surgery is proven to work for many other types of cancer, research has shown mixed results about whether or not people with advanced kidney cancer benefit from surgery. Immunotherapy is a type of treatment that helps the immune system to fight cancer. Instead of directly attacking cancer cells like chemotherapy drugs do, immunotherapy drugs may strengthen or change how your immune system works to attack cancer cells. Today's newer immunotherapy drugs can work very well against advanced kidney cancer. The immunotherapy drugs in this trial are standard of care and are FDA approved. If you've already started a treatment that includes immunotherapy, or if your doctor determines that an immunotherapy is a treatment option for you, you may be able to join the S1931 study. If you do join the study, you may or may not be assigned to have surgery to remove your kidney tumor. It's important that you know what you can expect in this study and how it compares to your other treatment options. You will hear next from doctors who are leading this trial. They will answer some questions that patients often ask. As you gather information and look at your options, Ask your healthcare team as many questions as you need. Taking notes is often very helpful.
Hi, I'm Dr. Ulka Vaishnapayan. I'm the lead oncologist on the S1931 study. You'll start treatment in this study with one of several approved treatments that include immunotherapy. Even if you've already started immunotherapy, you may still be able to join the trial. After you have 10 to 12 weeks of treatment, you'll have a CT or MRI scan to check on the cancer. If your scan shows the cancer has gotten worse, your part in the study will end and your doctor will talk to you about treatment options. If your scan shows that the cancer has shrunk or has stayed the same, your doctors will then carefully determine if you could safely have surgery. If surgery is a safe option for you, you'll be asked to continue in the study. You will then be randomly assigned to one of two study groups. People assigned to one group will be asked to have surgery and then continue immunotherapy. People in the other group will continue immunotherapy without surgery. Remember, being in a clinical trial is always your choice. Joining this trial does not stop you from getting other treatment in the future. You can change your mind for any reason at any time. Many people want the cancer removed as soon as possible. This is a normal reaction. But with today's immunotherapy drugs, there might be a reason to start treatment while the tumor is still in place. Lab studies have shown that starting immunotherapy while the kidney tumor is in your body may actually allow your immune system to gain information that helps it identify and target the cancer. With immunotherapy, we have to think about how your body and the cancer might be affected over time. Eventually, leaving the kidney tumor in place might cause the cancer to change in ways that make it harder to treat. And if the immunotherapy treatment does help to shrink the tumor, it could then be easier to remove in surgery. Earlier research has not shown clearly whether removing the kidney tumor is better for patients. Some research studies suggested patients who received older immunotherapy drugs did benefit from also having surgery. But a study published in 2018 that used another kind of drug therapy found that patients did not benefit from having the tumor removed. A key reason we're doing this study is that today's immunotherapy drugs work very different.
I think it stopped. You guys don't.
This is a dramatic pause. It works.
From the drugs that were used in those earlier studies. We really don't know what the effect of surgery is with these newer drugs. Our goal is to answer this question so that patients.
Oh my God, it's majorly buffering. Okay. If we can fast forward a little to the, maybe. Okay, that doesn't happen when you pull up the video, I'll tell you that. I tried it for. If, should we go ahead? Okay, yeah.
And doctors can make better decisions.
Okay, all right. Well, I'm sorry, but you didn't get to see Hyung on the screen, so I was trying to get to his section. But anyway, so you get the idea that we created this video. You know, the people on the screen you see are really not the people who made this happen. And the behind the screens people is who I really want to thank. I mean, without the Hope Foundation, Joe Horn is here. So thank you, Joe. And, you know, all her team, Morgan Cox and multiple other people really were the ones behind this. All the beautiful graphics, the script and everything has just come together very nicely, I think. So Well, we haven't transmitted. This is the first playing of the video. We just got it last week. So I think now we'll start sending it to sites so they can, they probably will, it's already CIRB approved. So we will have to just start sending it to sites so they can start showing it to patients or whoever else is interested in the study. Okay, so we're going to start, I guess, with Hyung's presentation on SWOG 1931, the probe, which is what the video you just heard.
Okay, sorry to interrupt. Is this video going to be like posted on YouTube or something, or?
Yes, okay.
It
will be.
And I think probably embedded in the study page on the website as well.
The only thing that scares me about the video is I have a patient who comes back and quotes every word that he listens to all my videos, and it's very creepy. So that may happen to you.
All right.
Just.
You want to comment on this?
Yeah. Okay, and I know we discussed, Ian actually talked about this yesterday also, but we just wanted to acknowledge Peggy Zuckerman, who really helped us for the last multiple years. We activated 2 phase 3 trials with her on board and with her help, and you see her in the video, of course. We completed and reported 2 randomized trials also. So, big milestones happened with Peggy's help. And we are looking forward to her continued guidance through the SWOG RCC GU committee, and best wishes to her for the future. And here were Brian's special thanks that he had also. And of course, we introduce our new kidney cancer patient advocate. We're very proud to say that she was on a SWOG trial. She had ties to SWOG and was Dr. Vogelzang's patient. I mean, if that's not a sign, what else is when we were interviewing her? And she's remarkable in terms of just the communication and the patient blogs and how many patients she has helped and inspired with her story, and with actually being willing to share it and guide patients through that. So thank you, Laura, for coming on board, and we are thrilled to have you. Can you stand up so we can applaud you? So excited. Okay, now we can start. And because this video had to be played at one end and we were playing it up front, we started with the advanced renal session. And now we're going to have Dr. Kim present on the SWOG 1931 study.
Thanks, Oka. So I want to also add my sincere gratitude to the Hope Foundation for helping us make that video. The video was almost over, so you got to see most of it, but we will start to promote it, and we'll rely on all your help and all your social media followings to get the word out. So because we watched the video, I don't think we need to spend a whole lot of time reviewing the schema. Hopefully this is something you guys are all familiar with, but this is the randomized study looking at the role of cytoreductive nephrectomy. Here's the important slide. Here are the accrual numbers. We're still just getting started. You can see the heavy sort of lifters here, University of Michigan, Tulane, and the investigator. We all know who the investigators are. The numbers by month are shown here. We were hoping that the 7 was going to be a trend, but we've fallen down a little bit to lower numbers the last 2 months. So would this be a good time to sort of get some feedback from folks out there on issues you might be having opening or accruing to this trial?
So we'd love to get any further feedback. I mean, I think last meeting we did get the feedback about, it was a tough study to explain to patients for anybody to understand and talk about the options. So the video should hopefully help you guys with that discussion. And if there's any other glitches or things, we'd really like to hear from you. There are multiple sites that have opened this. So the opening and activation is not too much of an issue, But literally, if we have every site put on 1 or 2 patients, we'll be done with this study. So just keep that in mind. We can really do this. It's a tough study to do, but a very important one. It's not a drug-related study. You know, this is a procedure that we need to figure out if our patients have to have it or not, if it really makes an impact on their survival, with overall survival as the, you know, gold standard endpoint. Any questions or feedback?
Yeah, I guess I would say I really am enthusiastic about this trial, but I haven't enrolled anybody on it yet. So I just wanted to explain something that I've learned. I hate talking to patients about trials that then I find out they don't qualify for, right? It's a huge waste of time. It disrupts enthusiasm. So what I did when I saw the schema originally, I was like, there's 2 points of entry.
Correct.
I'll treat them. I won't talk to them about the study. And then I will figure out on those like post 4 doses of ipi/nivo or whatever, will they be eligible? So that was my strategy initially. But what I found is just because of workflow, that made it difficult to then at that point start introducing the trial to the patient and still meet the time windows. And so that's some of the problem that I've had in the past. So I've recently now started trying to change what I do. And I've started talking to some patients about it earlier. So anyway, I don't know if anyone else has that same experience, but that's just something I would give us feedback. Don't necessarily wait and bank on that second time point as you can enroll it. It makes it tight logistically.
Yeah, I mean, I think that you're right, Ben. The scheduling of this with urology consult as well as the scans have to happen within that 10 to 14 weeks window. And what I've been typically done is I've set a reminder for myself if I'm starting the patient and not registering them up front. But the other way, I mean, my staff actually tells me it's easier for them if I register the patient up front, because then they follow the calendar and they tell me, okay, now it's time to get urology involved. It's time to do the scans. So I basically tell patients, if you're going to consent them up front, I tell them that 2 things will be the main things that will determine. First of all, that the treatment is benefiting you, whether it be response or stable disease. And the second one is that if the urologist thinks your tumor is resectable and you can get through surgery. So those 2 things will be determined after the first few weeks of treatment, and then we will randomize you. So until then, you really shouldn't be thinking too much about the randomization process. But that's how I've typically discussed it with patients.
Yeah, and I was just going to follow up. So I think at our center, you know, the medical oncologist and I have a very good relationship, and I think getting the urologist involved very early helps. You know, you can introduce the study to the patient. The video is going to be very helpful. You give them the link to they can learn about it. Then they come to the surgeon early, and it's an easy visit for me, although you end up talking a lot. But you look at the scans, and you look at the scans with the patient, and you say, yeah, this is resectable. You might be a candidate for this trial, and you let your medical oncologist know. So I think with the workflow and the time after that, you know, that 12-week scan, that really helps us. And so our current barrier is just that the patients that we have, unfortunately, continue to progress. And so that's the other challenge, sadly.
Yeah, no, I agree. I had 3 patients who I had pegged for this, and a couple of them are in the hospital now with toxicities. So that does happen, unfortunately. And it happens much more than what we thought before from the toxicity predictions from the papers, honestly.
It's a very, very important study. I guess one of the limitations that may be out there is obviously with the emergence of other IO-based combos. You know, some people might find that as an obstacle, right? And so I would like, that's the perfect, I guess, question that, can you update us on the amendment allowing any IO-based combo, which should make it really simple, you know, to get patients on PRO? Can you comment on where we are with
Pedro,
that?
the amendment is through, and that is what is active now. So any of the five FDA-approved regimens frontline are okay to use. So Cabo-Nivo, Len-Pembro, Axi-Pembro, Axiavelumab, and Ipi/Nivo, any of the 5 you can use.
Right, that's that's great news, because that pretty
so
help
that will
people.
help, of course.
Thanks, Alka. This is a great study, and I'm all in to support it. I just want to reinforce that
so far, the patients that I've put on the study are referrals from urology. So it's
Okay.
really, really important, I think, to keep reinforcing the study to our urology colleagues, because
Absolutely.
we tend to remember IO studies more than they do, but I would keep reinforcing, because all my referrals have literally emerged from the urology clinics. And I also wanted to thank you because we got the amendment letter, so it's good that all the regimens are here, and also the treated brain metastases has also been
Correct.
clarified. So I think that message also is not out yet. So I would, if you can post on Twitter or, you know, whatever
Good.
way, because.
Yeah, no, that's good advice. And also any histology, so it can be unclassified or, you know, non-clear cell, et cetera. So just keep that in mind, absolutely. And then in terms of the surgery date, you know, even if you randomize the patient, you still have 6 to 8 weeks to plan the surgery. So to pick a surgery date, I think it's 6 weeks. But, and is that adequate? I mean, I'd just like to hear from urology to see if that is at all a problem or an obstacle.
I think 6 to 8 weeks should be plenty of time to schedule.
Okay.
One thing I would add is, you know, we have 5 combinations, but please resist the temptation to open competing trials. You know, I get along very well with my medical oncologist, but when I refer patients to them, we do have a competing trial looking at bevacizumab as a third agent. And so, you know, they present all trials to the patient, and the competing trial definitely hurts us at our center.
But this is a third of the overall metastatic kidney cancer patients. So the patients who've had nephrectomy, you can still enroll on that whatever new agent study, and then keep this one, still be able to prioritize this one.
So just a quick question, because good morning, because some patients, actually quite a few, occasionally have their urologist perform surgery at one center, right? They have an oncologist at another center. Is that a concern with this study, or is that something that can be accounted for?
Yeah, everything has to be done at one center. SWOG requires all the investigators to be registered with SWOG, so that's a structural requirement we have to meet.
Okay, thank you.
I mean, we had talked about whether we, you know, consider fixing that or changing that, but so far we have not done that, but that's under discussion.
So the 6 to 8 week window, any problem with making that more liberal, you know, extending that? Is that a concern to the urologist? I only bring that up because at our institution, recently, we fixed it now, we had a run on anesthesiologists that sort of put some surgery dates a little off schedule, and that impacts things like this. So is that cast in stone at this point? Is there some give, just in case?
I think, you know, Lucky, when they randomize, you have to give a tentative date for surgery. So you'll know, and if needed, you can sort of delay the randomization if you have time within that 14 weeks to delay it a little bit by 1 week or here or there.
So Lucky, are you saying that they can't get him in for surgery within an 8-week window?
Because of the anesthesia issues. Yeah.
I was just thinking about, wouldn't it be nice in the ideal world that every patient who presented, who would be potentially eligible at the get-go, the urologist who saw that patient would at least mention this to them. And the only way that this would actually happen is if a urologist, because not all urologists are participating in you know, cooperative group trials, but if somehow we could link those urologists with an investigator, be it SWOG or one of the other cooperative groups. So I'm just going to throw it out. I don't know how to do this, but there's a lot of smart people that are probably on Zoom or in the room. Maybe young folks can come up with an idea on how we could potentially partner with the AUA. I don't think we have to partner with the SUO because we want it to be a bigger end than that. And then to partner them and to be able to give them almost like you enter your zip code and this is your referring doctor, or this is your list of referring physicians. So somebody who's smarter than I am, can you figure out how to do that? And that would then enable us to at least plant the seed from the beginning, and then the patients can drive it from there.
Yeah, and we also have a CME accredited presentation. So if physicians want to hear about it, there's a CME credit lecture describing the whole landscape in general about what nephrectomy, the pros and cons in metastatic disease, and also, about the probe trial.
Is there an NCI site that you could enter your zip code and know where you could do this? Does that exist?
Well,
No,
you
I
mean,
just don't think so.
clinicaltrials.gov
Yeah.
is that, but it's not very patient-friendly.
Right. Oh, yeah.
Maybe, Laura, we can get your help with the patient advocacy groups. And now that we have a patient-friendly facing video, if you can help get that out there on the internet, because everybody Googles their disease, right? So if they can find this video, it's a way for patients to get direct information.
Just one point to follow up on what Ian mentioned. One thing we've run into is that insurance covers visits for urologists, but not med-onc. And so we can get referrals in from our urologists, but then they can't continue their care with the med-oncs here. So that's going to be an issue with linking up with medical oncologists too. Maybe it's just specific to California, but it's I just wanted to bring that up.
It's metastatic disease.
Yeah.
So why can't you get into
because like the surgery is something specific to an academic
different.
institution, but the metastatic treatment can be done at their local oncology office.
I see.
So that's just an issue.
Yeah. Also, the other thing I wanted to add is the pembrolizumab every 6 weeks is also allowed now. So, the number of visits to the center can be minimized with that. Okay. All right. Thank you for that feedback, and please keep plugging away at the study. We need to get this done.
Okay. I think we've pretty much covered this, so I'm going to skip and just leave this slide up.
Yeah, just hold on. Okay. And then we also have multiple companion studies. So this was the young investigator training. Our Christiane Berger got the Young Investigator Award for doing the quality of life surveys with this. She's devised an expectations of cure and patient perspective, trying to assess that in the metastatic space now with getting these long-term remissions. So just, I don't think she's on now. And is Ben here? Okay. So Ben, do you want to say a few words about SWOG 2200? We heard a lot about it. It just got activated. So now we're definitely looking for sites to open this and get started. So if you want to say a few words and review things that we discussed already today morning.
Yeah, so thanks everyone for your feedback and comments from this morning. It's really helpful. Appreciate your support. It was just opened. We are really excited to start spreading the word and having people get it approved at their centers. Let's start enrolling these patients. If you have any questions or concerns, I'm happy to talk to you about it. Just email me, text me, whatever. So.
Just to remind you, this is the study schema, and this is in metastatic papillary cancer. So we have the eligibility and then the sample size, looking at 174 patients to be enrolled. PFS is the primary endpoint. And we have Canadian collaborations already set up, and we have a bunch of young investigators who are going to be doing correlates. So, even on probe, we have a lot of young investigator interest, and we are looking and hoping to have them do multiple subset analyses. And there is tissue, there is blood, there is all these correlates that we are going to be eager to look at, and then of course the patient-reported outcomes. So a number of different correlates are huge opportunities for you to work on the studies with us. Then the current pedigree study, which is the frontline study of Ipi/Nivo, followed by, depending on response, the patients get adaptive Cabo or Cabo/Nivo. And the concern is this triplet study, the Cabo Ipi/Nivo that just got reported at ESMO, showed an improvement in Progression-free survival, is that going to be a problem for frontline consideration of ipi/nivo? And turns out it's not going to be an issue because we don't have overall survival benefit as yet, and just the PFS of this triplet is not adequate at this time to justify switching to the triplet regimen. Anyway, so these were the responses, 43% versus 36% for ipi/nivo, so not terribly different. And this is the pedigree study design. This study is doing remarkably well. It's already close to 1,000 patients or so accruing. And here is the accrual graph, and SWOG has done very well, 96 from SWOG. I would say if you have the study open already, because this was open before probe activated, please try and consider only the post-nephrectomy patients can go on this, and the patients with the synchronous primary and metastases should please consider probe for those patients. And then the amendment highlight, they had some radiation language allowing radiation to the primary, et cetera, and but hopefully those patients should be going on probe. Okay, so I guess not too much to announce about this. The study is doing well and is likely to be done by, I imagine, spring to summer next year. Okay, this is the whole study team here. And then I'll have Mamta come up and do her 2 studies that she's the champion for SWOG.
Thanks, Alka.
Yeah.
So just a reminder about the Aaron 1721 study. This much beleaguered study is in an important patient population. So this is for treatment naive TFE3 translocation subtype RCC patients. Tends to be affecting younger patients, very aggressive disease. It's run through the Children's Oncology Group with Jim Geller as the PI. The primary endpoint is progression-free survival for this study, and the target accrual is 40. It's been open since 2018. There was an amendment that was placed that dropped the single agent axitinib, so now the 2 arms are axitinib plus nivolumab or nivolumab alone, and allows for crossover. And so the current accrual is 15, but we still have nothing through SWOG. So if there's any chance for you to open it through your site, please consider it. We'd love to have more patients on this. We're getting closer.
Well, only to say, Mamta, that it's a COG study, so chances are it's already open at your institution. Because as you know, at your institutions, all COG trials get activated.
Yes.
They keep those trials open forever. So
if you find
it's already open.
Yes, it's probably already open. And if you find an adult patient, please try to put them on the trial. There's mostly just pediatric patients on this study at this point. So in slightly better news, the RADICAL study is Rana McKay's study. This is a study looking at cabozantinib plus radium-223 versus cabozantinib alone. There was an amendment put in place for this study as well. So now you only need 1 metastatic bone lesion that was untreated with prior radiation therapy. You can't have had prior cabozantinib, but can have been treated with immunotherapy in the past. This was activated in 2019 as well, and there are 30 approved sites. The target accrual is 210, and right now the accrual is at 35. We have 6 from SWOG, but would love to have more patients on. I know Pedro has put some patients on, and we've done some at UC Davis, but I think there's room for a lot more participation. So hoping you all can consider opening this at your site and putting patients on, and feel free to email me or Rana if you have any questions. Like Alka mentioned, there will be a conference on November 2nd to get more information. It's a joint investigator meeting with the pedigree study. So look forward to seeing you guys there. Thank you.
Thank you. And this is specific for bone metastases in kidney cancer, pre-treated patients too. Okay. Then we have Pedro's concept that we'd like to spend a few minutes just presenting.
Hello, everyone. So I think some of you already saw this. We've talked about this concept we're trying to put together, I guess, last meeting, I think. And And so I'm going to go relatively quickly through the background and just focus on the design and what we can do. We're basically focusing on the post-adjuvant. We all know that, in general, IO-based combos emerge, and we talked about them. We have a number of them we're using for most patients with advanced RCC. What happens when they progress is still a lot of debate, right? TKI is the standard of care. However, there's these emergent data from Lee, from Sloan, and that basically supports or asks the question whether or not it makes sense to do salvage checkpoint inhibition after progression on prior IO, right? So this data with LAMP-PAM, the paper is out, and you see there over 50% response rate in the second line for patients progressing on prior IO for metastatic disease, and you see their RPFS over a year, right? So it's very promising data, again, revisiting the role of IO in the refractory setting. And so looking earlier in the course of the disease, and we see, we had a number of important studies they're being conducted in these last several years. Here's kind of the lay of the land, Of course, we got some news there from ESMO, but we got a lot of these data there from, Prosperity Motion, Keynote, and Checkmate, although we still need to know what the Part B is going to tell us. And we still have 2 ongoing studies that are really asking the question about the role of IO in any different shapes and forms in post-radical or partial nephrectomies for these patients. But the reality of it is, the data that really changed our management is the data from Keynote 564 that Tony presented now, updated follow-up with over 30-month follow-up. And so here's the summary. I don't have the breakdown by risk. He enrolled intermediate, high risk, and post-metastasiectomy. We are anxiously waiting for OS. The good news is, actually the hazard ratio dropped from 0.54 to 0.52 from the 2-year follow-up to 30-month follow-up. And so, and it's a positive trial for disease-free survival, which is a primary endpoint. And we've been talking quite a bit exactly, are we doing this in clinic or not? So I actually posted these on Twitter. I got the slides a couple of days ago. Actually, we got over like 240 or 250 answers we can find on Twitter. What's interesting about the results is about people, what are they really doing? 10% looks like a little bit less than 10% on the updated results. It's like, I'm never going to do adjuvant pembro. We have about a quarter or 20 to 25% of people who say, you know what, I need to see the survival data, saying that if OS is positive, yes, I'll definitely going to do it. And then we have around 3 out of 4 people or treating physicians who considering it either to eligible cases and more people of those actually doing it for the high risk and post-metastasiectomy, right? So this I guess, what a lot of us in the Twitter world are thinking about Keynote 564 and how they implementing that in clinics. So our thought process is, with all this said, we really think there's really still a need to understand exactly what we do for patients who fail checkpoint inhibition, especially in the non-metastatic space or in a curative setting. So actually, we designed this initially in the adjuvant setting, but in reality, it might be the case where we have a perioperative approach and we want to be flexible enough. So the question is really, is there a role for checkpoint inhibition post-progression on a checkpoint in the non-metastatic space? And so, we thought about that, and we kind of put this as a draft for us to discuss as a design where, we're taking patients with a clear cell component, recurrent with metastatic disease, who got and progressed on checkpoint inhibition, PD-1 or PD-L1 plus minus CTLA-4 inhibitor in the non-metastatic space, to get either a TKI, cabozantinib, arguably probably one of the most effective TKIs out there, or a combination of cabo-nivo, and with the thought process that cabo-nivo, the combo is really known, right? Right now, it has actually a very good safety profile. And we also thought a little bit about who would be the patients where doing such an approach would make sense. And we thought that perhaps limiting those who progress within 2 years would make sense, because I think in real life, if you progress 4 or 5 years later, let's say you got pembro, you progress 4 or 5 years later, more likely than not, you will be offering an IO-based combo, at time of progression. So we're really trying to answer the question about, is there a role? But on the other side, if you are on adjuvant immuno, for instance, and you progress while you are in immuno, after 3 or 4 months, that's really a different patient population than those who actually complete treatment and then progress, right? So that's why I guess the eligibility criteria defining the progression or the last checkpoint between, one dose and the 24 months post completion of that goal, to make sure we get rid of the primary progressors, those where, IO is unlikely to be beneficial, and also those where you progress, many years later, where likely we're gonna revisit an IO-based combo.
So Pedro, can we ask for feedback?
Absolutely.
I think this would be a good point because clearly a lot of things changed. There are 3 negative studies in the adjuvant setting. Is this still a relevant question post-IO adjuvantly? First of all, if almost everybody's using adjuvant IO, and sounds like that Twitter goal seems to tell us that, but also in this room, I'd like to see if you're using it and if this is a relevant question. Go ahead, Monty.
Yeah, Pedro, I think this is a terrific design. I led one of those negative adjuvant studies, but despite that, I'm still sort of in that category in your Twitter poll of folks who use pembro very consistently in this setting. And yesterday, Dr. Thompson sort of challenged us to really sort of think big. What's a trial we could accrue well to in this space? I think lots of my colleagues in the community as well are using lots of adjuvant pembrolizumab. I'm starting to see these patients already who are failing, and we just don't know what to do with them. So your trial really addresses a great niche. The other cooperative groups have already tackled frontline. We have a frontline trial. There's also trials out there in the adjuvant setting. So this is a space that we could really, stake a claim in, and I'm very supportive.
I appreciate that, Monty. If I may add, one of the feedback that I got from, I think it was the last meeting, pharma was trying to put something similar together, with 2 different compounds. And I just found out I actually, because they saw the data with the adjuvant atezolizumab, and actually that study is no longer moving forward. So I guess we'll be the only ones, which might be an attraction, we'll be the only ones right now in this particular space, at least that I'm aware of. I'm not aware of a large study being designed in this space. And my only comment to Monty's, about the other studies, of course, we're all thinking about CONTACT-3 and TiNivo-2, that basically asks, cabo-atezo in the 2nd or 3rd line metastatic setting, and then TiNivo 2nd or 3rd line metastatic setting, which are doing, cabo-atezo or cabo, and then TiNivo or Tivo. But that's much later in the game. So, and it's also not asking the question specific about what exactly is the role, right? We just do it the role and it's later in the game. So I personally, of course, I'm conflicted, but I personally think that this asks a different question, a different setting, and it makes it different from perhaps other studies that we have out there.
I feel like in the community, when patients progress on adjuvant pembro, most people are going to be using cabo. So it will be pretty close to their standard practice, but they will get the opportunity to consider a clinical trial with that. But yeah, Jorge?
So just to expand on your point, you may be accurate that in the community people we use cabo. I think the bigger question for us is, do we have to be married to cabo-nivo, or could it be a lem-pembro combo as well? Right. And secondly, when you look, I don't think we truly know what the definition of IO primary refractory disease is in the adjuvant setting. I would argue that maybe a 12-month mark would also be appropriate for us to use right at a 24-month mark, right? So just keep it similar to what we use in platinum-based therapy or what have you. But I think the combo is the bigger question for me, right?
So
that's a good.
Great point. So we've been back and forth 12 to 24 is, so it's a great comment about that. And of course, if we expand a little bit, potentially have more patients, right? Those who recur beyond the 12 month. And then regarding the combo, there's, the reason why we decided that we're not sick to cabo-nivo, of course. Cabo is arguably one of the go-to for the monotherapy. For the combo, the safety profile seems to be better. But with that said, there are other opportunities. You mentioned LAMF-PEM as an example. Another one is a new drug coming up, XL092, which seems to be have a very good safety profile and perhaps similar efficacy, if not better. We don't know that yet, but it's a great point about what we think about it. Yeah.
So for the sake of time, let's get feedback and then we can move along. Go ahead. Jim?
You know, the focus of adjuvant therapy, the adjuvant therapy space is now developing combinations, and those are all the new trials that are being planned and opened. What happens if one of those is positive? Is this still a relevant question?
I think the answer to that is, should we even be looking at combination adjuvant studies when single agent, each of these have not quite shown us efficacy? But yeah, that's a good point. We'll have to keep our eyes open for that.
I'm not sure about the timeframes of those. I mean, this may be relevant for the time being, and this can be a gap. I'd be careful about using a dealer's choice approach toward the combinations. We've never really shown that, that Nivo is better or equivalent to Pembro, and I would keep the checkpoint the same. I would keep the regimens the same. Also, the issue of PD-1 versus PD-L1, it may be completely different.
Yeah.
So either have different arms and power it accordingly, but don't make it such that somebody can select
it
different
will be a
regimens.
decided regimen. It's just which regimen is what we're discussing.
I think everything I wanted to say has already been said. So I just would quickly frame it like, I agree that the comparator arm is really pretty set. We know that's the best one, but the investigational arm, I think that needs to be, I think we need to keep an open mind about it. Whether adjuvant will remain, as Dr. Petrolak pointed out, relevant, it's a different question. But if we have patients that progress on immunotherapy, that experimental arm, I think you can argue that you should, if you have the patient on Pembro, why don't you try to salvage it by adding something to that, and we have Pembro-based regimens that you can explore. So that's where I think most of our focus should go.
Thank you, Sarma.
Yeah, no, that's a good point. And we are actually considering which exact regimen, with the latest changes, triplet and things like that are definitely things to consider for this study. So thank you everyone for that feedback. And in the interest of time, I'm going to move along we're going to start the localized kidney session. I am going to see if Brian can say a few words, but otherwise I will be driving it.
I'll I don't know if you guys can hear me.
Hey, Brian. Okay.
Sorry, guys. Yep. Thanks.
Okay.
Sorry, my son is RSV. It's going around, so we'll just move forward. A lot to cover. If we can just advance. Okay, so we have monthly meetings. We'd love to have some ambitious young future stars, thought leaders, or maybe even over-the-hill investigators. We want to advance the localized space and reinvigorate it next. So we'll just kind of have Lucky give us a kind of a brief update. People who don't know, Prosper was presented at ESMO. Mo Alaf gave a great update. Lucky was one of our SWOG champions. We did very well. We had about 200 patients on the trial. So if Lucky could just give us a brief push through of the final data.
Sure, I'll go quickly over the Prosper results. We participated in this trial as a group. It's part of our deal with the intergroup as part of our perioperative approaches in early stage kidney cancer. This was presented by Mo Alaf at ESMO, and these are his slides. I'll skip the rationale for Prosper. We've previously discussed that in this group. Just a reminder about the schema for the study. There's a neoadjuvant component with nivolumab for one dose prior to the nephrectomy versus the other arm, which is a partial or radical nephrectomy followed by observation. And the primary endpoint, just like all of the adjuvant studies, is recurrence-free survival. OS is a secondary endpoint. Now, this was the study population that ultimately enrolled in the trial. There were 400 patients in each arm, total of 819. Here are the summaries here. 50% were T1, T2, 15% were node positive, and 3% were M1, and most were PS0. More than 60% of subjects had pathologic T3, T4, and 60% or so had high-grade tumors, and 80% had clear cell carcinoma. Only 5% underwent a partial nephrectomy. And 45 patients in the Nivo arm versus 19 in the control arm received no surgical intervention at all. In terms of adverse events, it's not a surprise that those who received an active anti-cancer drug had more toxicity. Here, it was considerably more toxicity in the nivolumab arm. You can see up and down this table, there were more adverse events in the Nivo arm. And although there were serious AEs, such as grade 5 that were the same in both arms, one death that was attributable to nivolumab was myocarditis. But it is telling that single agent nivolumab has such considerable toxicity in this trial. And these are the particular toxicities with an incidence of over 10%, fatigue, abdominal pain, nausea, down the line. So these are not surprising for a checkpoint inhibitor, and we'll skip this. So at the interim analysis for PROSPER, which by the way reported out on time, versus Everest, which took us a while to collect events, here they were able to detect enough events to declare that there was a futility. There was no difference in RFS. I mean, it's as negative as it gets, right? Hazard is 0.97. You can see those curves. It's green because blue and yellow is green. They've just completely overlapped. Now, in eligible patients, the RFS analysis also showed no difference. And when they analyzed this trial, compared to the Keynote 564 study of single agent Pembro, there was no difference in RFS either. So here are the fantasized reasons for why this was a negative trial, but the Pembro single agent study in the adjuvant setting was positive. They said that enrollment in this trial was based on clinical stage results and resulted in overall lower risk population. Perhaps Nivo and Pembro are different after all. Maybe one dose of neoadjuvant Nivo was not enough. And then the adverse event rate, which was much higher in the Nivo arm, may have influenced the results. So I won't read you the conclusions. I think we went through that during the presentation. It was a disappointment. And it came on the heels of other disappointments with IO in this setting. The Nivo IPI adjuvant study was also negative, which also was a surprise in the context of a single agent Pembro study being positive, New England Journal paper, which I know that Monty said that routinely in the practice that he sees in his community, people are giving Pembro routinely. These sort of data gives us pause, right, about what really is the activity of immunotherapy in the adjuvant or perioperative setting. It has to give you at least some pause. And what Pedro showed earlier with the Twitter poll he had, that a lot of people were just really reserving pembrolizumab in those with the highest risk disease, perhaps the M1 populations that are completely resected, because there you have some justification in your heart that you're treating really M1 disease and basically impacting on people's outcomes. So in this trial, I think there was harm. There was no benefit in terms of efficacy, but there was harm in terms of toxicity. So this was the right study to do. We answered the question. Now we move on. All right, that's the update for PROSPER.
So if we could, we'll have Chris talk about Everest, and maybe we can talk about, thoughts about these trials and discuss some of their newer concepts, which we have two to present quickly.
Thanks. I'll run through this quickly. I presented Everest at ASCO this year. I didn't present the data at the spring meeting because of the embargo. It was an LLBA. So, the data, like you just said, was a disappointment about immunotherapy, but it kind of puts these results into new context about adjuvant therapy. Sure, so let's not forget about everolimus. So when I presented this study, these were the data regarding adjuvant therapies. Five TKI studies, only one of which was positive, STRAC, and the one positive immunotherapy, the Keynote study. Everolimus, this is S0931. We designed this in 2009 when everolimus was approved for metastatic disease. And there's reasons we could think why this may target the cancer cell directly, the mTOR pathway within the cancer cell directly, as opposed to immunotherapy potentially, and VEGF inhibitors, which might inhibit the microenvironment. So this was the design, as you are all well aware. Let's pay attention to the risk categories. I'll get to that in a minute. Everyone from patients with T1B high-grade tumors, okay, we don't consider that high risk anymore, up through node positive tumors, and both clear and non-clear cell, which differentiates this from the approved therapies like Pembro. Although they're approved broadly, they weren't studied in non-clear cells. A year of everolimus or a placebo, recurrence-free survival, just like the other studies, as a primary endpoint, with OS as a secondary endpoint. So this is what we need to pay attention with. So patients were classified as either as intermediate high or very high risk. We modeled this exactly on what they did in the ASSURE trial. So intermediate high was T1B high grades up through T3A low grade tumors, and very high risk was T3A high grades up through node positive tumors. And this was the stratification. Some shenanigans with the sample size, originally 1170. We had a lot of dropouts in one arm, not surprisingly, the everolimus arm early on. And so we increased the sample size in 2015, which we were estimating 4.9 years RFS in placebo versus hopefully 6 years with everolimus. Well, time went on and things seemed to be longer than that. There were four pre-specified interim analyses, and the final analysis was to occur at 804 RFS events. However, we weren't seeing events as we expected. So in December of 2020, we kind of drew a line in the sand and said that we're going to do the fourth interim analysis in March of 21, which was done, and the study was told to continue. And we would do the final analysis in March of this year if the 804 events had not occurred. And they did not occur by March of 21. We did the final analysis with a total of 556 events, okay? And this was the disposition, 1,545 patients randomized. As you can see, completion rate of full year of study therapy was only 45% on the everolimus arm versus 69% with placebo, 37% early discontinuation rate due to adverse events on the everolimus arm, and a higher discontinue rate due to disease recurrence on the placebo arm. Patient characteristics. Let's just focus for this presentation on the risk grouping. 55% very high risk, 45% intermediate risk. This is more treatment delivery. I mentioned the high dropout rate. There was also 37% dose reductions on the everolimus arm. Adverse events, not unexpectedly, this was a cause for most discontinuations, 46% grade 3 or higher adverse events with everolimus. This was predominantly mucositis, which was probably the biggest bothersome side effect to patients. So GI, skin, pneumonitis, which is a known side effect to mTOR inhibitors, 13%, only 1% grade 3, so that was not a significant issue. And the laboratory abnormalities were as expected with hyperlipidemia, anemia, and hyperglycemia. So here are the results. Hazard ratio of 0.85. First of all, the median was not reached in either group at the time of the final analysis. You can see the curves separate. They separate early. This looks very similar to the S-track curves. It looks, and if you truncate that very early on, it looks similar to the Pembro curves. Yeah. Okay. This is a long follow-up. You see the 12-year mark on the end of the curve. Median, I skipped over it. The median follow-up, I think it was 72 months or so. Hazard ratio 0.85, favoring everolimus. The one-sided p-value was 0.025, but the how come it didn't show up, Brian? I think he changed the background. What's missing at the bottom is the pre-specified threshold for significance was 0.022. So we missed it by 0.003, and because of the, well, the p-value was lower because of the multiple interim analyses. So it just narrowly missed statistical significance. Here's a forest plot. As you can see, everything is favoring everolimus. The one thing that sticks out as being significant are the very high risk group. And the African-American data are interesting, but unfortunately only a small number of patients in that demographic category, something we can talk about looking at later. So here was the difference by risk group. On the left are the very high-risk patients, T3A high grades through node-positive disease. You can see the curves nicely separating, median RFS 5.3 years with placebo not reached with everolimus, hazard ratio 0.79 and a p-value of 0.011. On the right, the quote-unquote intermediate high-risk patients, superimposable curves. So just to point out, this left curve, this is essentially nearly the same population as STRAC or PROSPER. This is mostly T3 patients, patients with T3 tumors and high-grade tumors. So, there's a lot of what ifs. What if we had focused on this group? Would this have been a positive study? Like all the other studies thus far, however, no overall survival benefit, not really adequately powered to see that, but we'll continue to follow this as will all of the other studies. So we said that it improved, everolimus improved recurrence-free survival, but did not reach the nominal significance level by 0.003. And the effect seems to be most pronounced in the very high-risk patients, which is really the focus of our adjuvant studies and our discussions of which patients we should treat these days anyway. There was a high discontinuation rate due to AEs. However, if you look at other adjuvant studies, even oral therapies within and outside of renal cell, we do see high discontinuation rates for patients in the adjuvant setting with oral therapies. And I'll point out, despite the high discontinuation rate, we saw this nearly positive result. So it really brings into question, well, how much adjuvant therapy might you actually need? Do we need to prescribe this for a full year or not? And so especially in the light of the recent studies, I kind of feel that we're obligated to continue to think about mTOR inhibition. This is now an oral, generically available agent. And I think it deserves at least discussion of where at the table for the future adjuvant studies everolimus should sit. I think it should sit at the table. So.
Thanks, Chris. So we have about 2 or 3 minutes just to discuss where do we go from here based on the PROSPER, everolimus data, and then we'll put up a couple of concepts from our colleagues at ECOG Alliance.
Question?
So the African American subset data is interesting. I know it's a small subset like you showed, but is there any pharmacogenomic or pharmacokinetic analysis that can be done to generate hypotheses and do a small study potentially in that population?
Well, we certainly have samples. I think Brian is going to talk about the initial plan for translational medicine analyses. But I think it's something we definitely need to dive into that would be of interest, especially if someone's interested in taking that on as a project.
Okay. Thank you. And
Laura, quick comment. It's more a comment than a question, sorry. So I think that the biggest issue that I see with earlier stage patients is that their risk tolerance and tolerance for side effects not good, right? Yeah. So if this could be done, perhaps not in a clinical trial, but maybe in a clinical setting to your point, a lower time frame for them to have to be on the treatment, I think you would see actually a vast difference in them being able to stay on treatment longer.
That's a good point.
So,
yeah, shorten the treatment. Okay.
Great.
Right.
So we'll talk about 2 concepts that are moving forward. I will just say that de-intensification of therapy was brought as a concept, and there was a lot of pushback from some patient advocates that we should not try to focus on de-escalation. We should try to figure out how we can do better So one concept looking at less Pembro time versus more Pembro time was kind of killed before it moved forward.
Yeah, the Ipi-Nivo was a negative study, and that was 6 months duration. So there is some concern about that.
So if we can move to Shuchi quickly to just go over the concept from, there were a couple concepts between Alliance and ECOG trying to look in the where we go from here, but Brad McGregor is going to kind of try to bring this forward, the strike concept, and Shuchi would be potentially our champion if this moves forward. So Shuchi.
Thank you, Brian. So despite all the discussion we've had, there is another adjuvant concept that's being proposed through Alliance. It's a short-term concept going in line with what was just suggested. So they are proposing to include patients PT2 grade 4, so standard, RCC localized setting and higher. Patients who have not had any systemic therapy in the past, they will be randomized after nephrectomy to receive. So it's a 3-month intensification with Axi and Pembro, and then they'll get 3 additional months of Pembro alone, and then this will be compared with 3 or 6 months of pembrolizumab alone. They are going to allow axitinib to be dose reduced, 1 dose reduction to 3 milligrams twice a day, and then the standard endpoints like disease-free survival, overall survival, and other endpoints. I'm not going to go through this, but based on previous data, they are expecting a 90% power based on a 0.025 one-sided alpha, and hoping to accrue a total of, depending on how many patients are accrued every month, the study duration is going to be around 5 years or so. They have key correlative questions that can be answered as we know there's a lot of tissue that comes from adjuvant studies, and there's also plans to collect plasma samples to try and see if there's any determinants that will help us identify the best candidates for adjuvant treatment. And so they are planning to collect MRD assays, obviously is going to be a big part of this trial. They're going to be collecting 3 Streck tubes at every Pembro dose, and then the tumor is going, and they have plans to look at methylated tumor DNA, because that's the one of the recent interest areas. And then there's tumor availability, which is going to be collected in the form of FFPE blocks to look at transcriptomic signatures, look at the tumor microenvironment, and see if there's any tumor factors that's driving the response. And then they are going to be collecting 2 EDTA tubes, plasma and PBMCs, to look at cytokines and immune cells to see if those were drivers to response to these therapies. Again, lots of discussion about why DFS, and there was a recent study at ASCO 2021 where they presented data on how patient level data was presented, where how OS is potentially could correlate with disease-free survival, and then FDA has accepted disease-free survival as an endpoint in adjuvant setting. And axitinib, the benefit of using axitinib, it's a short half-life drug. Dose reductions are allowed to 3 milligrams twice a day, and the toxicity profile it's easy to follow along. If patients have toxicity, it's a shorter half-life. So if you stop it, you can it's just easier to handle these drugs as compared to those which have a longer half-life. And then, of course, we can discuss this eventually, but there's already been a lot of discussion. I'm not going to go through this. We've seen many negative trials, but as a matter of fact, Keynote 564 still remains a positive trial. So that's the reason they decided to use that as the comparator arm. And it looks like this study is going through the steering committee soon, and hopefully with feedback from you guys and feedback from Alliance and other groups, they can refine or modify as needed, but that's it.
So it's not the most exciting trial, I think that, yeah.
So Shuchi, do they provide any rationale to support this? I mean, we have negative data with axitinib in the adjuvant setting. I don't think we have any data that axitinib plus Pembro is better than Pembro by itself. So why move this into the adjuvant setting and subject patients to the toxicity with any rationale for increased efficacy and even negative data?
I think they started off with proposing a neoadjuvant study. They had plans to first include axitinib in the neoadjuvant study portion of the trial, and then they were going to continue the combination. But I agree with you. I don't necessarily know what the rationale is of specifically choosing these drugs unless it's because of pharma support or. And then they're also trying to answer the question of the duration of response, because they are planning to treat only for 6 months, which I know has been raised, like, do these patients actually need a total of 1 year of treatment or not?
I think,
Go ahead, Shilpa.
yeah, I just want to make a comment that the flip side of it was also that, we don't have any data on whether shorter duration is the right thing to do.
Yeah.
So just wanted to make that point. I know a lot of patient advocates feel that we should not be de-intensifying without having any data in that setting.
Yeah, I just wanted to point out too, I think this trial has been through multiple, iterations at the task force level, initially separate concepts from ECOG and Alliance. So no matter what we say about the study, it's going to move forward. I personally think that looking at this big picture, the best play for us is to support whatever design they move forward with and really sort of create a case for ourselves to lead in that post-adjuvant setting. That's my thought.
Yeah.
With the trial.
Okay, if we can move to the other concept. So again, any thoughts we can give to Brad, but this looks like it will be moving forward. For the, go to next slide, just going to show up the schema.
There were,
Yeah,
Brian, there are a couple of people
okay,
who
just very
Do we
quick. So I
have
think
2
this
minutes?
is something that doesn't get discussed as much in the Keynote 564 study. Whatever happened at the European Union was really good for that study, right? I mean, if you look at the forest plot, the hazard ratio was 0.49 at the European Union, and I think in the mid 0.8s for North America. So whatever happened there was really affected overall results. And you don't see such a huge difference based on the geographic region usually in trials. I'm not aware of any other trial that showed such a huge difference. So had that been study conducted just here, that would have been completely negative study, right? So that's one point. And the other point is PD-L1, we still don't, we haven't really incorporated that in the testing, but in that study, it showed a potential benefit and hazard ratios of, including that as potential, selection of patients. But I just thought the hazard ratios never brought up what happened at the European Union for that study. Yeah.
That's a good point, Mark.
This is actually a question for Ian. So it hasn't gone to the steering committee yet. So is there any possibility of adding a third arm with Pembro everolimus? I mean, that would be, I think, an interesting scientific arm to have.
So true. I agree. I mean, everolimus needs to be in the mix.
I think we'd need some data before plotting that into an adjuvant study in the advanced setting, right? I can't think of a paradigm where you wouldn't have that level of evidence first and then push it into adjuvant. It is. No, but the combination, right? You have to demonstrate activity with the combination, otherwise it won't.
No, but single agent is better. Okay. Anyway, we're not going to solve this here. Okay, Brian?
Okay, so just so we can just give some brief feedback. So Asim has brought this a non-clear cell concept. We had discussed this in SWOG a couple years ago with placebo versus atezo-bev, which was the concept discussed. But if we just put up the concept here, this has been brought to the task force once. Go to next slide, just a schema we can put up. Just next slide.
We looked at.
Yeah, next. Yeah, next. So basically, we know there's activity, Nivo, Cabo, and non-clear cell. In this study, there was a 47% response rate. So we know IO has some activity. We know Cabo is active in the first-line metastatic setting. Next, they've obviously looked at, go to next slide, Len-Pembro in the metastatic non-clear cell with good activity in papillary, 52% response rate with a great waterfall plot. So next slide. So this is our current concept to try to move forward in a non-clear cell one, mostly probably going to be papillary patients. They're going to exclude collecting duct and renal medullary. Right now, the thought is to do the 2-to-1 randomization, and they've gone back and forth with doing 3 arms single agent versus dual agent, but this is the current concept, which would be 2-to-1 randomization of len-pembro versus observation or placebo. I think we can have a good justification why there should be a placebo, with potentially some patients going on single agent pembro if they can get through insurance, even though it's not on the NCCN guideline. But looking for some feedback, we can have maybe a 1 or 2 minute discussion before we hand it over to Deepak for the final. Is this the right combination? Asim is open to some suggestions and thoughts on placebo and the 2-to-1 randomization.
Question from Lucky.
Yeah, this is a showstopper because you need a biopsy before you do anything in this trial, right? Because
this is no post-nephrectomy.
No, it's post-nephrectomy.
But no way, go back. Isn't there, says high risk non-clear cell followed by nephrectomy?
Yeah, how are you going to?
Yeah, how are you going to figure out their non-clear cell?
It's nephrectomy, Lucky. So
No, but the eligibility up front prior to nephrectomy, it's requiring you to have non-clear cell. That's just my.
No,
I'm just interpreting this
so
thing.
post-nephrectomy, you look at it. Yeah, good point. Ben?
Yeah, I guess ideally what I would like to see is, instead of like a single cohort, really think about this in terms of each individual pathology, right? So develop the analysis so that we test it in each specific histology, because that's I fear we're not learning from the era of Everest, I mean, Aspen and ESPN, et cetera. Like, it may be a negative trial because of patient enrollment, et cetera. So if we could somehow make it disease specific, that would be helpful.
Yeah, of course, there are challenges around that, as we all know, with very limited sample size. Okay.
Also, no placebo.
Yeah.
Either everolimus or pembro, right?
And Cabo versus Len, any thoughts to give back to Asim?
Okay, anybody has strong feelings about, is it good, len-pembro? You guys are on board for the adjuvant?
I guess one comment about that, I actually like the idea of lenvatinib because now it's a rare disease and it's harder to do trials in rare cancers. So now we're getting some prospective data with more agents. So I really like the idea of lenvatinib, since we have multiple trials now through SWOG using cabozantinib. It's nice to see a breadth of other agents being prospectively tested.
Good.
Okay, and our final talk from Deepak. Deepak can come up. And I think we have about 7 minutes before we have to turn it over to our colleagues.
So Deepak is our young investigator who just, did you do the course recently?
Yeah, I did the course. It was fantastic. Very grateful to everyone for the wonderful opportunity. And my dad asked me how it went, and I used the word transformative. And so thank you all.
Wow.
So this is our concept. We've presented it a couple times, maybe 3 times here. And we presented this at the Young Investigators course. And so there were some changes that we made with that. So I just wanted to sort of first start very briefly with the background. Patients present to us with a newly detected small renal mass. At the bottom there, you see the typical options: surgery, ablation, or active surveillance. But this role of biopsy has really always been unclear. And so there we go. So we know that the incidence of cancer has continued to rise, kidney cancer, over the decades, yet the mortality is unchanged. And that's when you look at this sort of pie chart here, when you look at majority of these tumors, if they are cancer, are low risk, up to 20% or so are benign. So patients are often being overtreated. And still, we do have 10% of those kind of wolf kind of tumors. And we would expect to see this in about 5,000 to 8,000 patients per year. And so this is just to highlight the change in the wording. We really wanted to remove standard of care because we were worried about insurance coverage. So the patient shows up with a newly diagnosed renal mass at the sort of the bottom figure, and you're randomized to biopsy or a mandated biopsy. And then there's shared decision-making and standardized follow-up. We're going to go through a couple of those things very quickly. So one thing we changed was the inclusion criteria. On the right is the, after the meeting, in the idea of being pragmatic, like we talked about yesterday. We really wanted to expand enrollment to all people, and people use life expectancy. There's a lot of debate about what that means. Use life expectancy tables, Charleston comorbidity, but we figured if you just leave it up to the surgeon, and if the surgeon, if she decides that the patient is amenable to biopsy and treatment, that's good enough. And so, what is, this kind of got crunched together here, but what is the real endpoint for this study? And the idea is that renal mass biopsy will result in the avoidance of treatment or over-treatment of patients that may have benign masses or low sort of indolent tumors. So this really kind of messed up on here, but essentially, we have, initially our outcome was we're going to follow these patients for 5 years. Everybody talks about a 5-year outcome, but there are a lot of other data, there's a lot of other data that influences the decision to proceed with an intervention when you follow somebody out that long. And so, do we shorten that data point to 2 years? So how does renal mass biopsy influence the decision for treatment within 2 or even 3 years? And that's, when you look at the sort of the disarm data with the Johns Hopkins for the active surveillance data, most patients, even on active surveillance, will make their decision within 2 to 3 years. And so that was one point of discussion. Is we really want to focus on the discussion for this part, but that's kind of what we want to talk about. This is the workflow. Makes sense. You show up with a mask, you see the doctor, they introduce the study, we have a video, and then if they're agreeable, they would get randomized. Most patients end up coming with a single phase scan, so this gives us an opportunity to get a multi-phasic scan. And for this study, we've proposed an MRI. There's a clear cell likelihood score that we would be using as a potential integrated biomarker. And patients would then be randomized to biopsy. We're going to throw another sort of video after the biopsy to really help counsel patients. And then there's visit 2 with the physician. Other points that we wanted to talk about is if a patient chooses active surveillance, do we mandate how that is done? Do we say every 6 months for 3 years and then annually for 5 years? And if it's a benign tumor, are we going to mandate that they get some sort of imaging in a year? And this was another sort of curveball that just came into the mix. So there's CA9, which has been around for a while, membrane staining. It's very sensitive for clear cell kidney cancer. And there's a randomized trial that will be presented. I'll just point to it here in ASCO, where they have about almost 300 patients, and the data is still, I guess, being analyzed, but the preliminary data seems like it's very favorable. So if we have a study, if this becomes FDA approved, and this becomes the standard of care, how does this really impact this potential biopsy trial? Because if you presumably have a study like this, where a patient can then just choose to just get this FDA PET CT scan, does it kind of bury the study? So do we integrate this into the study? Do we offer everybody gets this PET CT and then they get the biopsy? Do we say, well, should we give everybody that PET CT and only those where it was equivocal, we offer a biopsy? Because this is, again, very sensitive for clear cell. And so that's really what we wanted to focus on. The endpoint, the 2 to 3 year endpoint versus 5 years, and then also what people thought about having this new sort of potential FDA approved imaging. Thank you.
Imaging study, is it compared with the partial nephrectomy or with biopsy?
So, Ian, I'll be presenting this at ASCO GU. It is a phase 3 single arm trial. Every single patient had to be booked for partial or radical, and the histology was to truth. So the prior study led by our colleagues from a company called Wilex, which died when the Ariser adjuvant trial went down. It was about an 88% sensitivity and 87% specificity, and the FDA wanted them to do a larger trial. The company shut down. This company was basically Telex, which has a PSMA product, which they also resurrected this, which is the same antibody. It's just labeled with zirconium. So they basically, we would expect, probably similar performance as it's the same antibody, just with a different label. Right, nephrectomy, yeah. So
Yeah.
this was a nephrectomized cohort as the histology is truth. But the question for everyone is, if this moves forward, how does this impact this study? And do we build upon this and have a biopsy in the CA9 negative group, because that will be likely the non-clear cell tumors?
I think the discussion about the best endpoint has to do a little bit with what the surgeon's going to do with the results of the biopsy. So my understanding, I'm a medical oncologist, but if you have a small renal mass, even if it's clear cell RCC, those can be observed, as long as they don't grow, they don't have to be resected. So can you elaborate a little bit? I mean, you went through the biopsy results, plus or minus. If it's benign, patient will be observed, but what if it's clear cell RCC, and what do you mean by aggressive histology on the biopsy results?
Yeah, so it's kind of a foreign concept because almost every cancer gets a biopsy before you treat it. And majority of patients, we would still expect to actually undergo some sort of treatment, whether that's surgery or ablation, because most patients won't accept active surveillance. If you have competing risks, you're old, frail, many of those patients will. But if you biopsy it and the biopsy comes back as benign, you've now potentially counseled the patient and you would avoid treatment. And that can happen up to 20% of tumors that are in this size range that we have. And so, and then if the biopsy comes back as, papillary, or if they can give us a grade on the tumor, that's something we've been trying to look at. If they can say grade 1 to 2, and if you're a little bit older and maybe you have some significant comorbidities, you may opt to observe for a while closely.
A couple quick questions. So is the MRI mandated? Like if they've had a 3-phase CT, the size, it's a really nice scan. Are you mandating that MRI?
So we wanted to see if we could get that in. I don't think we're going to exclude anybody if they can't get an MRI.
Okay.
Yeah, so if that's
So you might have to pay for it if you wanted to mandate it. And then your question about how often to do the imaging. We've learned a lot in the active surveillance for prostate world, and my recommendation would be to have the minimal requirements, because if you're every 6 months or 3 years and it hasn't changed at all for 2, are they really you're gonna have a bunch of mismeasures and protocol violations, and it's gonna be a headache. I mean, but set some minimal standards, okay? And the other thing is, are you collecting reasons for treatment?
Oh, we would catch.
Somehow, I mean, again, it's all in the, you have an older patient sick with a grade 2 small little clear cell, and they're going to want treatment. Is that really what everybody does, or is that a patient choice, provider choice? It's going to be really hard to understand that.
Yeah, I think we would, that's a good point, to just make sure, even in the disarmed data set for the active surveillance, when you looked at the reasons for why patients went off active surveillance, there was actually very few reasons. The patients just wanted it out. There was, there were the growth kinetics, but there wasn't really a strong signal there. And so, yeah, I think it's good to capture.
I mean, sorry about the follow-up question, but I mean, you mentioned most patients in your experience will actually have an intervention, but I think especially in a situation like this, where the eligibility was loosened to leave it up to the surgeon, I do think there's going to be contamination in a lot of patients who are going to enroll in this study who don't want surgery to begin with or have comorbidities. So I still don't fully envision that, if you get clear cell RCC, that those patients are going to have surgery or not. So I'm still unclear about the endpoints, or what the study is trying to accomplish with this degree of contamination that's going to happen. A lot of patients are actually not going to have treatment to begin with, even if they have clear cell RCC on the biopsy.
Yeah, so I want to make sure I understand that correctly, but what I would say is that we've built in a 10% contamination, and it's my concern with this study is also trying to really get people who are really committed to do the study, both from our sort of centers and patient-wise. Many patients will not accept randomization for this, and those patients will automatically filter themselves out. And so the hope is that when we have something like this clear cell score with an MRI, we're giving these patients these videos that are informative, that's kind of their, that's how you lure them in on the study, that, everybody wants a second opinion these days, and you're getting a virtual second opinion.
But the question is the question about the role of the biopsy, or the question is the role of the treatment?
The role is, how does the biopsy influence the treatment choice?
So it's a biopsy question predominantly.
Yes. Yeah.
So perfect. Thanks, Deepak. Any comments or feedback, please let Deepak know or me know. So we'll move forward. I think this concludes kind of our renal session, and hopefully we finished on time for
Thank you,
STEM.
everyone, for all your feedback. We'll definitely take it, and feel free to join our kidney renal calls. Happy to add you on the invite if any of you are not getting notifications.
Yes.
Yes.
Yeah. So we'll, Tom and I will roll into Bladder, and we'll kind of cruise through this pretty quickly, but we want to spend an appropriate amount of time on trials that we've got activated that need some help. So these are Tom and my contact information. Just a reminder that we have our monthly Bladder calls Wednesday, fourth Wednesday of the month, 5 to 6 Central Time. I want to thank Taj for all his support, and feel free to, I think for the time being, either email Tom or I if you're not on the distribution list for that, and we'll make sure we get you on it. This is our agenda, and we'll start with Dr. Sadeghi.
Thank you, Seth. Hi, everyone. This is SWOG 1937. It's a phase 3 randomized trial of eribulin and gemcitabine versus standard of care. It's a dealer's choice for docetaxel, paclitaxel, and gemcitabine. The potential candidate for this study is a patient who has had metastatic urothelial carcinoma previously treated and post-immunotherapy or ineligible for PD-1, PD-L1 antibodies. We had our first investigator meeting this morning, so some of you may have been in that meeting as well. I think the one request that I have for all of you today is that this study has been slow to open and accrual has been very slow. We really need everyone's help, and I'd like to ask each and every one of you to consider opening this study at your center. We are facing the possibility of study closure if the accrual doesn't pick up. With that, I'm going to quickly go through a few slides. Recently, we have had a few changes in the standard of care in urothelial carcinoma, and this has changed the landscape. I want to emphasize that this change has made SWOG 1937 even more relevant for our purposes for clinical investigation and patient care. We had enfortumab vedotin get approved for previously treated patients with PD-1, PD-L1 for patients that were chemotherapy or cisplatin ineligible. We have approval for nivolumab in adjuvant setting, and we have a frontline full approval for pembrolizumab. Previously, we had approval as an accelerated approval, not full approval. So this is the current landscape. The purpose of this slide is for you to see where SWOG 1937 fits in our spectrum of clinical settings and treatment options. I have not put sacituzumab here, and I explain why. We require treatment with enfortumab for patients that are being evaluated and screened for S1937, but we do not require sacituzumab. If you have treated a patient with sacituzumab, those patients are welcome to be screened for this study, but it's not an eligibility requirement. The reason for that is that currently sacituzumab is in its own phase 3 clinical trial against docetaxel and paclitaxel, so it's in a similar setup to what we have for eribulin. If you look at the accelerated approval in the study for sacituzumab, the response rate was about 27%. In a large phase 2 study for eribulin and a smaller phase 2 for gem-eribulin, response rates were higher than that. And so for those reasons, sacituzumab patients are welcome, but it's not a requirement as an eligibility. So the two studies that I mentioned, the eribulin phase 2 studies are shown here for summary purposes. Response rate is 35% for eribulin alone, 50% for gemcitabine eribulin. Median overall survival 9.5 and 11.9 months. I want to say that when we did these studies, we did not have immunotherapy or antibody drug conjugates. So these are relatively older studies, and these for the gem-eribulin, these are patients that were chemotherapy ineligible, and this is all they got. And similarly, for eribulin patients, there was no subsequent treatment for the majority of the patients on that study. This agent had good activity in visceral metastases and liver involvement. So again, that tells us that eribulin is a reasonable agent to explore in metastatic urothelial carcinoma. So the message here is that, despite all of these new agents, antibody drug conjugates, immunotherapy, et cetera, we still have a significant unmet need. Patients are not being cured in metastatic setting, and they inevitably progress through whatever we throw at it and end up in a situation where we're looking at either phase 1 or docetaxel. And when we are in that situation, I think all of us should consider SWOG 1937 for our patients. This is a very flexible study. Sequence of therapy, number of lines of therapy, these are not part of the strict eligibility criteria. As long as a patient has had enfortumab vedotin, has had immunotherapy, or has been deemed ineligible for immunotherapy, those patients are welcome to enroll on this study. Even patients that don't have measurable disease, if they have bone metastases only, they are eligible for this study. So very flexible and accommodating. We have 3 arms, 155 patients for each arm. The schedule of treatment is shown, and randomization is 1:1:1. So we have 2 experimental arms here, 2 out of 3 chance of patients getting eribulin. Again, I consider that as a positive for patients that are looking for an option other than docetaxel. This is the statistical design. I just put it up there in case you want to take a snapshot, but I don't want to discuss it. As I mentioned, this study has been very slow to open. We have had challenges, and I want to thank these investigators whose name is on this slide here. These are early adopters of the trial. I very much appreciate what they have done. And yes, of course. Anybody in the room? Who's on that list? Dr. Wang, Dr. Mamta Parikh, please. The GU committee has decided to recognize these investigators and their efforts in support of SWOG 1937. And yes, Dr. Severson, Dr. Verma, Dr. Taj, Gordon, Dr. Sumi, Dr. Badami, Dr. Berg, if you are here, please come forward.
Not Dr. Severson, but I will take it back to her. Yes.
You get this anyway.
called leadership by example. Leadership by example. A round of applause.
Thank you very much. Thank you very much. Thank you. Okay, so all those who are not here, we will mail you your certificate. Please send me your a good mailing address, and I'll see to it that you get it. Again, I very much would like to thank those investigators, all of you that are here, all of those who attended the investigator meeting this morning, and please open this study and help us keep the study open. I'm going to stop here. Thank you.
So it looks like Rick's got a question.
No, Rick has a comment. So I want to thank everyone who just got an award. And my first meeting at SWOG, we had S0337. And it was in a similar situation. I want people to understand this is serious. And we changed the standard of care. All right, so I will be working with all of you. And if you don't think this trial makes sense, tell us why. And if you think it makes sense, how can we make it better? We need this trial.
Thank you, Rick. Thank you very much. It is very true. It's a sentiment that the study team really feels very strongly about. So we are open to suggestions and ideas. We have a monthly call, and we'll send all of you the invitation with the schedule for the call. You're all welcome to join and discuss your suggestions, comments, and questions and concerns. Thank you.
I wonder if we could just get a show of hands. How many people have the trial open at their sites? And then thanks very much. And who's, maybe a show of hands of people that are planning to or are going to open the trial? A few more there. And then maybe just one last, because we're all here. Who has a concern about using docetaxel, a comparator arm, that's dissuaded them from accruing patients? Anybody with that concern specifically? No hands. Okay, and people, there's about 30 people online. If you have any comments, put it in the chat and we'll gather that as well.
No, I think the bigger question for me clinically is how often can we see a patient that's having bladder cancer getting docetaxel today? My answer would be very rare for us.
I think that's one of the issues. You know, there's a larger, another phase 3 study going on with the same setup that's accruing, we understand, or at least the rumor is fairly well, but I think you're right. This is a later line. One of the things that SARMAT is focused on is that there's a lot of combination right now going on, moving up front from these therapies. So I think the way it looks today versus in even 6 months may change as you've upfronted a few of these trials. And so I know I was talking to a group recently, made that point, and they decided to open it saying, you know, you're right, we've got a ADC IO combo right up front, and then something like this could happen pretty quickly. I guess I was probing to a bit, Jorge, is docetaxel itself. So if it was sacituzumab or a different comparator arm, would that help enthusiasm or accrual?
I think the use of docetaxel is going to pick up again, because if we're doing enfortumab vedotin and pembro in the adjuvant setting and suddenly we have progressive disease, we do sacituzumab, maybe cisplatin-based chemotherapy, and then what? So we end up, quickly out of options as these agents move to earlier lines of treatment.
Just echo that. I had 2 patients I approached about this trial in the last month. They both elected to have sacituzumab now and then the trial later.
That's helpful feedback.
Hey, Sarmad. So I actually started the opening process for the trial at my prior institution and discussed this with the patients. The challenge we encountered is that the fourth-line urothelial space is a space that the patients are seeking multiple different kinds of opinions, and that includes referrals to phase 1 clinics, referrals to us. And so when we present the trial, where they've already gone through 2 cytotoxics or cytotoxic-like regimens, and then we propose to them, and historically, docetaxel has had a bad rep from. We'll know it's not particularly effective, and that's why this trial is important. But that also creates the challenge for the patient that they're getting alternatives in terms of like phase 1 options and other trials that they may be a little bit more attractive. So we actually lost a couple of patients in favor of those, even though they had less track record, because the possibility of not getting docetaxel was a little bit more attractive. So I don't think having docetaxel necessarily is a barrier from a physician standpoint, but after explaining the landscape and the available options, I think it may be a little bit of a barrier for patients who have access to other trials that are phase 1s or phase 2s, perhaps not cytotoxic directed. So
that is a very good point. I think when you are discussing a phase 1 versus a phase 3, I think sometimes the patients may not understand the distinction. They feel that, well, I'm guaranteed to get that drug, and that is a new drug, and that may just, change my life. If we explain that that drug is not proven, doesn't have any efficacy data, and primarily the goal of that phase 1 is to see how much of it we can give to the patients without breaking them down, I think that may change the perception, but it is true that on the part of the patient, the perception is, okay, I'm guaranteed to get something here that's new and novel and may just do wonders, versus something that may randomize me to docetaxel. But that comes as part of the patient education during that meeting.
And I don't think this is something unique to bladder cancer, this particular trial. I think it's true for all relapse refractory trial populations. I think it does help to have 2 arms having the investigational treatment, so the patients have a higher odds of getting the investigational drug rather than docetaxel.
That's true. I agree with you. That's a positive for the study. Thank you. Thank you very much.
Thank you all very much. I think the next one is...
You're going the wrong way. Forward.
Yeah, okay. So we discussed this previously, and is Michael Liss here? I don't see him. So Michael is the surgery co-chair. He's from UT San Antonio. Guru, are you on the line? I don't think so. Yeah, okay. So for those of you who were not here earlier this morning, let me just put up the study schema here. This is a randomized phase 2 of gemcarbo avelumab plus cystectomy versus cystectomy alone for platinum ineligible patients. This is called the GAP trial. Primary endpoint is pathologic tumor response, pathologic complete response, and a host of secondary endpoints, lots of interesting molecular and imaging correlates. Just pay attention to the cisplatin ineligible criteria. As we discussed this morning, the vast majority of those patients are going to meet this definition by virtue of some element of chronic kidney disease. I think we talked a little bit about maybe the sweet spot would be for patients, say, with an EGFR 50, 45 to 60, where I think that a lot of the medical oncologists are quite comfortable, certainly at 50 and above, using platinum-based chemotherapy, but this would create another option for those patients. This is just the treatment schedule. And then we've got some parameters around the surgery. I think the real important message is that patients with upper tract tumors are also eligible for this trial, and that currently would support an unmet need in addition to the patients with lower urinary tract muscle invasive bladder cancer. You can see the statistics there, a rather robust effect size built into the trial, and correlative studies, and there's pretty good financial support behind it. And so we really need to get this open really across our network and up and running. It's still very early in the trial, but we've got to really kind of move this along. So anybody have anything they want to bring up? Anyone online want to make a comment?
This is Shilpa. Sorry, I couldn't be there in person. So we have this trial open and we're putting our first patient on next week. I think just a couple of things to keep in mind for this. The visit burden with a provider is quite heavy in this because every day 8, day 15 visit requires a physical exam and ECOG performance status. So that perhaps in an upcoming amendment that could be considered. But we are pursuing this trial as our priority right now. Hope to put more patients on.
Thank you.
You know, I think it's really important that the urologists know that this trial is available because tendency is with a platinum ineligible patient to send them directly to surgery. And since this covers that group, which we really don't have a standard of care for systemic therapy, we really should also focus on letting our urology colleagues know that this is open. There are really only 2 trials are competing right now. One is VOLGA, which is involving enfortumab, and I think there's EV302 or 303, excuse me, which is looking at the same question with enfortumab plus pembro. Those are close to being closed, if I remember correctly. So this is a trial that serves a niche, and really I'm very enthusiastic about it. We're going to try to open it at our center.
Yeah, thanks, Dan. No, I think it's a great message. You know, I'd like to think that independent of whether a patient is platinum eligible for standard of care neoadjuvant chemotherapy, that they're getting evaluated in a multidisciplinary format. And but the urologist is generally the point of entry for these patients with non-metastatic disease. And so it really is incumbent upon us to be, you know, educating them about clinical trials, and then obviously have this one open. So message is received. Okay, so we've got a number of concepts in development that I'd like to spend a little bit of time with. I'll have Josh Meeks come up and talk about our subtype trial that's being run through the Clinical Trials Partnership with Genentech.
Hi, everybody. Good morning. Welcome to Chicago. Good to see everybody in person. So on behalf of the Subtype Clinical Trials Partnership team, and again, many of us from the Bladder Committee are represented on this team. It's my pleasure to kind of give you an update on the trial. Here's our current schema. And again, just to bring everybody on the same page, this is a trial for platinum-eligible muscle-invasive bladder cancer. And then the overall sample size would drop out and all is anticipated to be just under 700 patients. So the patients, when they get enrolled and meet entry criteria, their tumor is sent to Tempus for subtyping. That's an RNA-seq-based platform. And you know, there's a little bit of scientific controversy around subtyping, but we've really broke this out into just 3 groups. Tumors that are more luminal and have more differentiated pathways, tumors that are more basal and have more stem cell-like properties, and then those that don't fit into either one. The trial at that point becomes 3 individual phase 2 trials. So it's a platform overall, but it's actually 3 individual phase 2s. In each arm, there's an experimental arm compared to the standard of care, which is neoadjuvant chemotherapy. So for the luminal papillaries, the experimental arm is atezolizumab plus erdafitinib. And again, Janssen's providing erdafitinib as drug only. For the basals, the comparison is atezolizumab and terigolimab, so that's the anti-TIGIT. Those 2 are combined together. And then for the non-luminals, non-basals, again, those are tumors that don't fit into either one. The combination comparison is atezolizumab and chemotherapy. Patients then go on to have a radical cystectomy. And the comparison here is really a relative change, right? So it's a 15% relative improvement over the standard of care. Based on the Coxon data, the response rate for each subtype is somewhere between 49 and 53%, but that's why we have a comparator, and it's a relative improvement. And you can see each, like yellow, red, and green are all sort of the biomarker work that's being done, and much of that's being done in the future, but looking at urine and blood ctDNA, and ideally, hopefully, radiomics as well. So I'm just going to give a bit of an update where we are right now. So very excited to say that the study capsule was reviewed by the Clinical Trials Partnership and received sort of early approval with some revisions involved. So we've gotten approval from the Executive Review Committee. And currently, the overall trials with working between Genentech and the CTP for contracting and budgeting. Just as a drug update from our spring meeting, again, we received support or just approval in confirmation from Janssen to provide erdafitinib. Again, we think this is one of the best drugs in this space, targeting FGF receptor 3, which is strongly overexpressed in luminal tumors. Right now, probably the biggest work going on is the classifier. I mean, again, this is an integral biomarker study, so a lot of work is being done with that classifier. Currently, there's contracting between Genentech and SWOG, as well as Tempus, to really make sure this is being done and being set up appropriately. Once that is sort of contracting's done, there's going to be some internal validation of that classifier, and then a dry run with select institutions to make sure that once patients are enrolled, the specimen can go from their institution to Tempus and get a readout in a time that a patient's willing to consider waiting before being randomized. Finally, would say that, again, because this is a SWOG CTP trial, it's going to be run at SWOG institutions, but we're also looking to expand that out to other groups that have a strong track record of performing cystectomies with strong medical oncology and a good collaborative team. So we've just had multiple discussions with the SWOG CTC and hoping to hear from them soon. That's all my slides. Happy to open any questions and discuss anything further about this trial concept. I mean, I think, yeah, everyone's shocked. Some things that still need to be worked out. I was talking earlier, so, what if the standard of care changes? I think as we move along with, which can happen, right? I mean, it's a long trial, 700 patients, the standard of care could change. That would be great. But again, it's a relative difference. So as we go on to protocol development, we'll have to build in there if, let's say there's a new drug in this field that is doing great, what happens to the trial? So I think that's something we're going to have to work out.
Yeah, so the optimistic viewpoint is potential activation third quarter 2023, how these things go, maybe fourth. So this would be all platinum eligible patients where you're planning a radical cystectomy. So when you're thinking about, sequencing your trials and what's going to conclude and what's going to open, please put this on your calendar, and because this will require all hands on deck, and it will be, it's a game changer if we can get if we can put the patients on the trial.
Hey Josh, quick question. So with the existing, considering the trial includes a chemo IO arm in one of the cohorts, the existing data, although in biomarker unselected patient population in metastatic setting and multiple neoadjuvant studies hopefully reading out soon, do you anticipate a reluctance in enrollment of patients to that cohort if that data comes out, and how will we adjust for that? I know it's a different setting, it's a biomarker select, and they haven't really looked at that part, but any potential ways that we can kind of mitigate and make the case for why that combination is still worthy of combination and investigation compared to just chemotherapy alone?
Well, I can try to answer it, Tom. You can try to answer that. I would say that from a conceptual perspective, that data is not out. There's a bunch of trials that have started, closed, accrued, so we may have that information. But I think the problem with that is that those are unselected patients, right? And hopefully this is selecting a little bit more for those chemo-resistant tumors. And hopefully the concept, and again, we don't know how the path response is. I think Shilpa's had some very strong data that combining them is a little bit better than, for example, in the metastatic setting where combination hasn't been as effective. Short, high-intensity treatment may be beneficial here. And again, the other side of it is that you're not withholding care for any of these patients, right? They're still getting chemotherapy, so.
So we plan to do some plain language materials on this trial. And so things like that can be integrated into the plain language and adapted as we go along. Now, it is my belief that the plain language materials are more than the patient. They are probably CRAs and nurses and all among the community settings. All right, so I'll be looking for some help on that because I can't do it alone.
And just to highlight Rick's involvement, I mean, I think this has got to appeal to our patients and obviously to our patient advocates that these experimental therapies and subtyping, why it makes sense to wait, time before treatment. So it's a big part of the planning.
I love the design. I just guess, for in general, it's not just Bladder, but one of the challenges sometimes we think of, especially in the cooperative group settings, is the turnaround time with sequencing. And so, can you walk us through, what you guys have done so that we can perhaps apply this, to other tumor types where we'd love to do it.
Yeah, I think so that kind of comes into hopefully some of this dry run to make sure that tissue gets. Or consent happens, tissue gets sent from that institution to Tempus, and then results have to go to SWOG Stat Center, and then that has to go back to the site. So that optimization is critical, right? I think that's going to be part of the process that needs to happen between now and activation to make sure that those gaps. And again, we have people on the committee from pathology as well. So I think but we appreciate that patients don't want to wait. And if they have to wait before starting therapy, that's a problem. So
Seth and I just took a field trip yesterday over to Tempus, and they're expanding their capacity, building out at Research Triangle Park. I think that from what we heard, it seems pretty feasible.
Yeah, it was extraordinary. The operations and the workflow and the precision. Of course, it's they're doing clinical testing, but they also have extensive experience with a variety of collaborations and research, and they've placed a very high value on this trial. We did a poll. Perhaps many of you participated in that. My recollection, Josh, was people could live with a 2 to 3 week turnaround. You're shaking your head.
Well, no, I don't know that I know for another study we're doing similar.
Yeah.
And smaller phase 2, about 4 weeks, whether you expire. Of course, you also depending on the
Yeah.
So because the thing is, so it's a couple steps, right?
Yes.
Because I actually believe that the shorter will be the sequencing.
Yes.
So I don't worry as much
Yep.
with templates as I would my institution, let's say, how long
Yep.
does it take for them to set it up, right? And then once the tissue is there, they guarantee that short time frame.
Right.
Turnaround time, right? So
Right.
that's actually pretty expected, right? That doesn't
Yep.
change much, but then the additional step going, so, and so the question then will become, to you guys watch, right, is whether or not we think 3 weeks is okay versus 6 to 8 weeks, right, or something like that.
Yeah.
That's why I was, because it would be lovely to do this, not only for a field, but actually RCC,
Yep.
right?
Right.
We're going there, we're getting there, so it's great that these actually become successful.
And we've had similar issues with, for example, trials with FGF receptor alterations at our own place, and the step that makes the difference is talking to the pathology and saying, listen, the patient's sitting there waiting, and I know you have other stuff, because it's a lot of clinical flow. So, Tempus will accept blocks, they'll accept ribbon. I know most institutions don't like sending blocks, but for speed, that cuts them down from cutting sections. So I think that's something we're going to have to work through and anticipate that biomarker block to get that done, is critical for the patient.
Josh, sorry, this is just a follow-up to that Tempus question. Is the tissue going to be sent directly to Tempus from
Yes.
sites, or does it, okay.
Yeah, it's going to go directly to
Yeah,
Tempus.
if you want to do a dry run with us, we have a contract with Tempus, and
That's
we've
great.
been getting turnaround pretty quick, like within 10 to 14 days. So I wanted to, because if you have to go through central, then
No, the hope is
all
it'll
bets
go
are off,
to
right?
SWOG, and then again,
is our,
the data will go to SWOG, and then the nucleotides that are extracted, those will all get banked, and
Very exciting study. I think the key, like, it's been said, is the timeline for the logistics. We are, for instance, running in 3 to 4 weeks into getting someone scheduled for chemo, reserving a chemo slot. So in a situation like this, 3 to 4 weeks ahead, we're going to have to book chemo slot for patients for 6 different combinations. ahead of time to secure a slot, at TESO infusions, different time than you add chemo infusion. So there's a lot of logistics here. My other question is about the consenting. So when the patient first consents into the study, is the consenting just for, is it two consent process, or is the patient going to consent for all the possible systemic therapy options? It's a very long discussion to go over all these different drugs.
So I would say we don't have a formal answer for you, but I agree with the two. My own thought would be the two consent process. It's much easier to consent and get the tissue and get that started rather than saying someone worried about, for example, side effects of ERTA if they're never going to get it. So I think in general, our approach is probably going to be it, but that's got to be worked out in the protocol.
So one of your problems with this in logistics may be the Epic build. A lot of us are using Epic for our EMRs, and you can see a huge Epic build coming out of this. So perhaps what you could do is provide either one central place that can help out with sharing that with everybody, because that will be a barrier in getting this going. And in some cases, it takes a couple of months to get that build done. But if you have a model build for people who use Epic, that I think would increase the
that's a great idea.
The participation in this.
Because they're all going to have to do it. So that's a great idea.
Can I ask a question from Zoom?
Yes.
Josh, this is Scott Delacroix. If we were able to send, prior to consenting the patient for the trial, if we were able to send the tumor for sequencing before the patient even comes back for their Foley removal, it would dramatically expedite the process. So if we get the path back in my shop in 3 or 4 days, the patient may come back at a week for their Foley removal. It could already be sent off. So that way you're not having to consent the patient for the trial and then wait for the sequencing.
Well, yeah, I was. Scott, can you mute? Thanks. So just from a clinical trials perspective, I mean, you can certainly do whatever the heck you want in terms of, if you want to get the tumor sequenced. But the workflow here is for the trial, the patient has to sign an informed consent, right? And then the workflow at Tempus is, I'll use a term turnkey in the sense that they receive the block, they do all the things that they do, they generate the RNA-seq data, but the next step is they apply the classifier, the R package, which they have, and they'll do we're part of our kind of process leading up to activating the trial is to work with them to do some internal validation. They have to get an IDE from the FDA, but so all that happens. So they do the sequencing, they run the classifier, they determine the subtype, and it comes back to stats, and then it comes back. Then now you know what subtype your patient is and randomization, and Kathy Tangen has some things to add to that.
Yeah, no, I was just going to say, I mean, we need to have that initial registration one when the tissue's going in, because we need to be able to assign a patient number so that for step 2, we can have the programming done to assign them to the proper study.
Right.
So you can't just submit this.
So, Seth, can they do a pre-screening consent first? We've done it for other trials where they just sign the consent for the tissue testing. In fact, a lot of these neoadjuvant trials, like the Morpheus trial, has a pre-screening consent. And then once the tissue is confirmed by the sponsor, then we sign the main consent.
I'm understanding. I'm personally, I'm having a little hard time understanding what the question is.
And I was mentioning if we can do a pre-screen consent instead of the main study consent. That way the patient signs the consent for sending the tissue out.
So that's, if I recall correctly, and correct me if I'm wrong, that's how the Proof 302 study was done.
Yes.
In the sense that, so this was an FGFR targeted agent, and the first consent was, screening for the profiling that would give you whether or not the patient has an FGFR alteration that determined eligibility, and then there's another consent to be randomized.
And that's
so that's a good idea.
Yeah, and that's kind of what we were thinking.
If you did the pre-screening consent at the same time you're consenting the patient for the TURBT, that would be.
Yeah.
Yeah, so, yeah, these are great comments, very helpful. Anything else we can do to sort of speed up the workflow? I think for the surgeons, it's also, and Josh already pointed this out, is really, you got to be really closely working with your pathologist to say, look, patient may be eligible for this trial, this block, and et cetera. So, yeah, these are all quite helpful. Thank you.
Yeah, Perminder, can I make a quick comment?
Missed that.
Parminder.
Perminder here, can you hear me?
Yes, Parminder.
Yes.
So, quick short comment here. In workflow from medical oncology point of view, the first visit we get with the patient is the longest visit. The subsequent visits are smaller. And so it would be better if we have the subtyping before we see the patient so that we can spend more time talking about the trial. Otherwise, logistically, it would become difficult to get the second larger consent discussion squeezed into a smaller visit.
Parminder, it's a little challenging to understand you, but we really appreciate you calling in. Could you just please put that in an email, maybe and just send it to Josh and I and Tom, and we'll digest it. Thank you so much.
We'll do that. Thank you.
Thank you very much. I think, Scott, you're up next. Yeah, so just a preface here, having completed S1605, which is, a single arm trial for atezolizumab and BCG unresponsive disease, we really want to continue to try to work in that space. And so Scott Delacroix and a number of us have been working on the trial design that Scott's going to go through very briefly. Scott, can you do that?
Yeah, I can briefly go through. You can actually just advance the slides. You can go all the way through because everyone's seen all this. So the NCI has approved a clinical trials workshop that we're going to be doing in December. And so the slides that I made this morning was really of sausage making. So the sausage will be made over the course of the next month. Ultimately, what you see in these blocks, disregard them because it may not even be those drugs. But there's obviously, by the number of people who are interested and willing to participate in this clinical trials planning meeting, I think we will get something in this space off the ground. Ultimately, what it's going to look like, if it's a 3-arm phase 2, a 4-arm phase 2, or something more like a platform trial where we're able to add arms as we go, is to be determined. But stay tuned. Hopefully at the spring meeting, we will have a concept that's been thoroughly hashed out to be able to present. That's it.
Yeah, thanks. So conceptually, I think the field is sort of thinking, and we are thinking very strongly that, doublet therapy is the way to go. I hope people have the Alliance trial open, intravesical gemcitabine plus pembro. We recently activated and are looking for patients, so I think we should be supporting that trial. That's a nice approach to doublet therapy. For people who are not familiar with the drugs in this space, nadofaragene is intravesical adinterferon developed by Colin Denny. Sometime in the near future, that stands a decent chance of getting approved. The clinical data have been sort of reviewed extensively by the FDA, and they've just had to clear some hurdles with the manufacturing. And then N803, which is this IL-15 super agonist, which is given in combination with BCG. Those data look really good. It's currently under review. The FDA has set a deadline, I think, for mid-May to report out. So there could be some other new single-agent therapies that get approved in this space. But I think that combination therapy, most of us think that's the way to go. We use Gemdosi off trial as kind of our current standard. That's being studied now in a trial that Max Cates is leading in BCG naive patients. So it's sort of, it takes the slot for our current 1602 trial. And then, so I think that the mission, and Peter Black has really been very supportive of this. Peter is the surgery co-chair of the Bladder Cancer Task Force, which is doing the CTPM. And through a competitive process within the task force, this trial and another trial, this design, I should say, and another design were prioritized. And so there's an optimistic scenario where this sort of design comes out of the CTPM, and then, we'll have to get working on it. But, okay, so Scott, thank you so much. Let me kind of cruise through this. And, yeah, there's, no. Oh, okay, yeah. Leslie. So Dr. Ballas, we've been, a bunch of people have been working with her on this trial design that won the competition. We're the Radiation Oncology Committee. Sort of now it's kind of moving into the GU Committee.
Thank you so much. So this was presented yesterday, and so I'll go through it very quickly so it's not too repetitive for folks. But this trial is looking at response-based trimodality therapy following neoadjuvant chemo in patients who select cystectomy up front. So patients select cystectomy and neoadjuvant chemotherapy up front. They have a clinical T2, T4A, and 0. They receive at least 3 cycles of cisplatin-based neoadjuvant chemotherapy, which would be at the direct discretion of the medical oncologist. They then have restaging with CT, chest, abdomen, pelvis, and or cystoscopy, and they look to have a clinical T0, T1 disease. They would then be registered onto trials, sign informed consent, and then they would undergo TURBT with template biopsies to confirm clinical T0, T1. Then they would be randomized to either chemotherapy with radiotherapy, kind of a classic TMT arm. And then the second arm would be radiotherapy with atezolizumab. These patients would be followed with cystoscopy and imaging with an option of salvage cystectomy if required. Primary endpoint would be bladder intact event-free survival within a primary objective of 3-year bladder intact event-free survival to be estimated for the 2 arms, with secondary endpoints looking at progression-free survival, metastasis-free survival, and rate of salvage cystectomy. We will look at quantitative and qualitative adverse events, as well as PRO CTCAEs between the 2 arms. In this space, a non-inferiority trial design is not feasible, and so we modeled our statistical design based on one that was used previously for RTOG 0712, which looked at sort of a 3-year distant mets-free survival in patients with muscle-invasive bladder cancer who were randomly assigned to 2 different arms. The 2 arms were not compared, but instead, both arms were evaluated to assess whether or not they would meet a primary endpoint benchmark. In this particular study, we're looking for each arm to have alternative hypothesis of 60% bladder intact event-free survival at 3 years, and that would lead to 123 patients per arm total. And so when we look at the schemas and sort of work backwards, if we have 123 patients per arm, there'll probably be about a 35% or so screen failure after the TURBT with template biopsies. It means we'd want to register about 370 to 400 patients for the trial. And that's really all that I wanted to show you guys. But I think that this is exciting to me because it brings trimodality therapy into a space where we are all seeing patients that sort of ask the question, is there a place to save my bladder after they've had response to neoadjuvant chemo? Thank you.
This is a nomenclature.
Oh, please.
It's a nomenclature. Can you go back to your original slide? The schema. It's the concept that the patients are opting for cystectomy, and nowhere in your slide is cystectomy. And I know why that's there. I'm almost thinking that you kind of divert after the TURB for those who may go that direction.
Yeah.
It seems disingenuous.
Oh, well, patients, so we have obviously the patients who opt for cystectomy up front, and then I didn't put it in the schema only because I don't want it to seem like it's a randomized trial for cystectomy, because that would, I think, be confusing.
Yeah, I mean,
we can.
I get it. I think it's really kind of, I don't know, there's this patient population is in transition, and how urologists and medical oncologists are collaborating and thinking a little bit differently about, the patient who has a substantial response. That could be a clinical CR, down staging. There's a lot of hand-wringing and concerns over understaging in that setting, but the reality of it is, I think that a lot of us, and Leslie and Sia Danishman have pointed this out, are thinking a little bit differently about, well, when we talked to you, it was, chemotherapy, then surgery, now it's time to schedule your surgery, and lots of patients are kind of looking at you like going, what? Well, or you could even just say, I mean.
I see what you're saying. Okay, thank you. That's a good point.
Okay, thanks.
Josh.
Leslie, I think this is great. I mean, I see a lot of folks like this, and you're having that discussion, and really my goal, first time I see them, is get them to medical oncology. I don't even talk about surgery at that point. I mean, we talk a little bit, but say, let's get your chemo and then we'll talk. And this is perfect for that. I think my only question really relates to the CIS. As a surgeon, I see a lot of CIS. Some of it is called, some of it depends on which pathologist reviews the slides. So you may get a benefit from the Atezo patients getting CIS, but like, how are you going to, I know you're not planning to include CIS in the beginning, but what happens if they have a CIS recurrence? How are you going to manage it? I mean, if we can keep them with BCG, that's great, but how are you going to kind of try to figure that out with your numbers?
Yeah, so, I mean, I think that we ideally do want to try to exclude extensive CIS, and, we could use the same wording that's used on 1806 for, sort of focal CIS, certainly, and include them. But ideally, we want to exclude them at that TURBT. And so in terms of how that feeds back to the numbers, that's a very hard question. The Zarger data that was done years ago does report CIS in a clinical setting after neoadjuvant chemo. And so we try to take those patients out.
Even when they have a recurrent, like if they have a recurrence afterwards, I mean, they're keeping their bladder, but it's a CIS recurrence. We sometimes treat them with BCG.
Oh, I'm sorry. So you mean later on, like after therapy? Yeah. Oh yeah, I think we could still, we would treat them as any failure, non-muscle invasive failure to TMT, and they could get BCG.
There may be a difference in those between Atezo and chemo.
I see what you're saying. Thank you so much for clarifying. That's a good point.
Hey, Leslie. So just wanted to add to Dr. Thomas's point. I think it looks that we're taking patients away from cystectomy, but I think that's just a reality of neoadjuvant chemotherapy, is that a lot of these patients are going to be coming from community and different oncology practices where the decision to offer the package of neoadjuvant chemotherapy and cystectomy has been made. The patient has been found to be cystectomy eligible and cisplatin eligible, so we're already past that sort of initial step. So I think we can rephrase it perhaps that it appears a little bit better, but I think that's essentially the population that was committed to neoadjuvant chemotherapy and cystectomy. And in principle, yes, we are saving some of their bladders at the last moment right before they were getting cystectomies, but I think that we can phrase it potentially a little bit better. Thank you.
Thank you. Oh, sorry, one other question?
So there was a patient who had the same hope of preserving the bladder. He wanted to participate in the Alliance trial, but he was ineligible due to history of prostate cancer in last 24 months. So how will you address this issue of patients wanting to participate in the trial to preserve bladder, but not being eligible to participate?
I guess they would, if they weren't eligible, they would,
No, but they want to participate, but they're not eligible. Like the ineligibility criteria is so strict that they can't participate in the trials to preserve bladder,
Yeah, I guess we'll have to deal with a patient like you're describing who had prostate cancer. We'd have to deal with how their prostate cancer was treated. Obviously, we can't give a second course of pelvic radiotherapy if they happen to get their prostate cancer treated with radiotherapy. So that will all be spelled out in the protocol, but I think that's a great point.
Thank you.
Thank you, Leslie. Okay, so the rest of this session is going through active studies, closed studies. This is going to be very quick. And then the other cooperative group trials. So very briefly, we've had a beautiful session yesterday. Really want to thank Ian for supporting the idea of this Bladder Preservation Symposium. Kind of did a deep dive into this trial. Obviously, you know, Parminder is on the road to the airport.
I'm here online.
You're here.
Online.
Okay, so. You there?
We'll move to the next slide. Yeah, so thank you so much for the support for this trial. This trial is accruing very well. If you see here, it's enrolling over 10 patients a month in the last 12 months. So it looks like we probably will finish off accrual by end of next year. Next slide. This is a new form which we have added to the protocol. This is not a mandatory form, but we are requesting documentation of TURBT and cystoscopy. This will encourage urologists to do EUA and document the size of the tumor, and also the complete resection will help us do better clinical staging. So this is an addition in the amendment, so please look out for this form. Next slide.
Before I do that, if you're online, please mute. All except, of course, for Parminder. Okay.
Next slide. Next slide. Yeah. So this is just a toxicity update which Samir Jawar is doing at Astro for us. So you have already seen this at the investigator meeting. Next slide. There's a slide, I think it got missed here, but there was amendments which I wanted to highlight is that we have to push for T3 accrual because we are lagging in T3, T4 accrual. So please help us accrue higher stage patients. This trial is open, especially if somebody is cisplatin ineligible and they are T3, 4. So please do encourage your sites to enroll that patient on. And there is a new blood collection. We are doing ctDNA for year 1 and year 2. So there is an amendment. So please collect that. That will help in the TM portion. So I'll end there. Thank you so much.
Great. Thank you. Just keep pressing on. Don't give up. We're like on this incredible roll. So, and a lot of cool science. Just to the update on the cool science part is David and Josh are leading an effort with NRG and some other folks because once we hit 75%, we can start writing grants, BIQ applications, and that sort of thing. So, Mr. Bangs.
Yeah, I just want to mention this is the trial we're going to try to reimburse patients for travel.
Oh, yeah.
All right, it's a proof of concept. My success criteria is paying the first patient and getting through all of the approvals and process, which has been kind of messy. All right, so I just want to let people know that's coming.
Yeah, thank you, Rick, for spearheading that. Thanks. Okay, so this trial, as you know, is completed, and Peter tells us, and Kathy corroborates that the manuscript is kind of close to being ready for submission, close. And there's a lot of translational science going on in the background, focusing on particularly the CIS population. And I don't really have anything else to add to that. Prime, as you know, has completed accrual, and Kathy and the team working with the FDA, we just had a meeting with them, and they were very eager to see the CIS data, which they've now seen. I guess I need to be quiet about that. So stay tuned. And this won't report out really on the primary endpoint for quite some time. But the motivation from the FDA, as you know, is the BCG supply. Merck supplies BCG to 70 different countries. They've had some challenges, not currently, but a lot of sites are just continue to struggle with getting BCG. And so there's a lot of intense interest in trying to bring additional strains into the market. The FDA perceives that this may be an avenue for that So stay tuned. Yep, did that. Closed studies 10, 11. The optimistic viewpoint is potential analysis now that we are essentially sort of at or very near all the patients having 5-year follow-up. And the plan is, I would say, a potential for reporting. The idea is to be able to report this at one of the spring meetings, but obviously a lot of work has to take place before then. And then we've got a lot of translational medicine also going on in the background with this. I unfortunately need to go to the airport. So I'm going to turn this over. Well, fortunately, I'm eager to go home, but I'll turn it over to Tom. And please stay here because there's a lot of other cool studies that are going on. And then he's going to present really a new trial that is approved in GU Steering Committee that Matt Galsky has spearheaded. And it's a great opportunity, I think, for us to collaborate. So Tom, thank you so much. Thank you all, everybody.
Safe travels, Seth. All right, we'll try to get done here as soon as we can and get people on their way. So not a lot of comments about 1314. We have the primary manuscript that has been published. That was with the primary endpoint of pathologic response. Thanks to all, we had embedded several secondary analyses in there. I think David can correct me, there were 4 abstracts last year for 4 different groups at major meetings using these samples. So that will continue. Appreciate everybody's efforts along those lines. There's more to come. I think we'll have a number of great activities. So I'll cover for these slides here. Other active NCTN trials. This is the randomized adjuvant trial of pembrolizumab. This is the ambassador trial. I'm going to go through these pretty quickly. If somebody in the audience wants to make a comment, raise your hand. Otherwise, we'll just keep rolling through. Here's the InVigor adjuvant data looking at DFS in this ITT population. There's the checkmate data, which we've seen before. Here's the schema for this particular study. There's a number of correlatives also with ambassador, which are shown here, including ctDNA. So it was closed in the fall of 2021, as I think a lot of us are aware. The accrual here from SWOG was 93. We should note that Guru enrolled 19 of those patients, so I think a very strong showing for our group. Here is the Alliance 31701 bladder sparing following chemotherapy in patients with select DDR mutation alterations. We have accrued 9 to this study, including 4 of those at UC Davis, so lucky and Amtar here. Shilpa is online and is our advocate. Shilpa, if you'd like to make a comment, feel free.
Yeah, Tom, yeah, we have enrolled 6 from Cleveland Clinic, and Gopal gave me the update that they've accrued 135 nationally and have a long way to go. So if anybody here would like to know more about this trial, this is an important biomarker driven trial and we want to support it. Accrual goal is 270 and 135 have been accrued so far.
Thanks for the update, Shilpa. Great to hear your voice. Here's the Alliance BCGN responsive trial. Our SWOG champion, Mark might be here. Mark, leave. We'll just touch base on this. There's the schema enrollment update. SWOG had 28 patients. Current enrollment is 78. Again, there's the schema. This is the phase 2 study of bladder sparing chemo RT with durvalumab, the INSPIRE trial. This is an ECOG Akron trial. I think Josh is here.
Yeah, so there's been an amendment, and if you can advance the slide. Yeah, so to try to increase enrollment for this, it's just started to try to enroll patients better. So it's meant, again, for patients with locally advanced disease, and to potentially receive chemo and IO. So please consider this trial. Again, it's a really important question for the community. A new amendment that we think makes it easier for people to go on.
Thanks very much, Josh. If there's any questions, feel free to reach out. Shilpa, I think, is on the phone for this call. So Shilpa, do you want to make some comments? This is the main COV.
Tom, I think Ed, who's the SWOG champion, is also on. I don't know if he wanted to present.
Yep, okay, very good. He's walking up to the mic. Take it away.
Thanks, Shilpa. Yes, not going to take very long to talk about this trial. So just please think about supporting this trial, opening it at your institution. So this is just, the main question is whether or not the addition of cabozantinib will add any additional benefit to avelumab maintenance after a first-line cisplatin-based chemotherapy and for metastatic patients. So far, the main key updates is that this trial has been open since March of this year. It's been about 7 months. We've had 4 patients enrolled so far. The planned accrual target is 654.
Thanks for a very
Please
succinct
support
update.
this study.
Go ahead, Shilpa.
I just wanted to request if everyone can support this study. It's an important study, and we want to accrue on this. Thank you.
Hey, just one real quick note. I think at our institution with the Medicare coverage analysis, we had trouble with the bone scan, as I recall, and that held it up. So
Yeah, we can make that as clinically indicated, Tom. We're noting those things for the amendment.
I agree. That would help us out, at least at our site. So thank you very much.
Thank you, Tom.
Thank you. Okay, here's, great, Dan, go ahead.
So thanks for presenting this. So this is a duration of immunotherapy question. I'm the champion for SWOG. Dr. Wei is the PI. So this is the question of patients who are getting to, let me just go.
Yeah, sure.
So this question is the patients who are getting to 9 to 18 months. So they've been on IO. It can be either maintenance IO, avelumab maintenance, can be second line pembro, but I suspect it's going to be mostly the maintenance patients. How long are they going to take IO for? We know there's a tail in the curve. Following the RCC data, the melanoma data, people are stopping immunotherapy after 1 to 2 years. In urothelial, this is an unknown question. If you can go back one real quick. So the question here is, patients get, the study randomizes at 9 to 18 months, offer the patient to either continue, assuming they're stable, of course, to either continue or to stop. If they stop, they have an option to resume the immunotherapy. It allows any of the immunotherapies being used for metastatic urothelial. This study has been slow to accrue. I suspect a lot of the problems are related to patients are reluctant or concerned about stopping if things are working. But at the same time, the way I talk to patients about this study is that there can be cumulative toxicities, right? Someone who's stable for a year and a half can still develop toxicities. Now, to go on this study, they cannot be ineligible to continue IOs. In other words, if they had too much toxicity, they're going to stop anyway. They're not eligible. They have to be stable and not have too much side effects. But again, is this question. So this is a big study. It's 1,000 patients, and it's accruing very slowly. There's 357 approved sites, but most people are not putting patients on study. So the study is probably going to close if it doesn't pick up speed. It's been open for about a year and a half now. I think from the big picture, it's a very big question. About 10 to 20% of those patients end up in plateaus. So do we continue forever or not? So that's a study. So if people can open the study and consider enrolling patients, that'd be great.
Thanks so much, Dan. Yeah, it looks like it's going to need some help there. All right, the next study is up on the screen. I'm losing the screen down here, which is all right. So this is the phase 3 study of durvalumab and chemotherapy in patients with high-grade upper tract. Anybody in the group that wants to speak to this? I'll go through the slides here. Well, there, it's back on. So here's the schema for the study. The screen was blinking there for a while. Looks like it's back on now. We're just going to go through this pretty quickly for your awareness. There are the primary objectives. Okay, this may be our last slide. This is a slide our colleagues in Alliance had sent over recently. This is protocol drafted, maybe a late draft. They're looking for our input and probably a consideration of a champion from SWOG. Pretty interesting, looking at patients post neoadjuvant chemotherapy. They're using the criteria basically we're using for adjuvant immunotherapy, so having YPT2 after cisplatin or a more bulky disease for those that did not receive therapy. Looking at detectable versus non-detectable ctDNA, that's the branch point. Based on that branch point, there's either treatment escalation for those that have detectable ctDNA. It's on the top part there you can see, which is interesting. In the bottom part, you've got nivolumab, the standard, versus surveillance. and that's looking with an endpoint of disease-free survival. Pretty interesting, I think, smart design there. So if you have any feedback, either speak now or talk to us afterwards. Any concerns or comments on this particular design? All right, we might be going to do the renal group here. So I think that's the end we have now for bladder cancer. Any final comments? I would just say this too. We'd love to develop some advanced bladder cancer protocols. So if you have ideas or concepts, even early ones, feel free to reach out to me. I'd be happy to talk to you, invite to the meetings, and cultivate some ideas there. I think we have some opportunities. Dr. Thompson, I think that's the end of our presentation. Oh, Mr.
Yes,
Banks.
so for those of you who weren't here yesterday, I just want to remind, tell you that my term and Tony's terms as patient advocates ends as of the April meeting. So be on the lookout for great patient advocates as you're working with patients. That's number one. Number two, I have an idea relative to doing a webinar on metastatic solutions that I may be reaching out to folks on, because I think the landscape is changing so quickly, and we've done this before, but it's like 2 or 3 years old.
Tony, are you still on? In the absence of Tony, can we give a little round of applause for Mr. Rick Bangs, who has been amazing friend of all of us and a friend of patients, and has had a tremendous impact on SWOG. So your legacy will continue for many years. The one thing I just wanted to mention is that I don't think, when you get a little more senior, you may have forgotten, I don't think we have a seminar title for the spring. Correct me if I'm wrong. And in the absence of a seminar title, that means that if there are ideas on folks, and so I challenge the organ site chairs and the other leaders, but anyone can propose a seminar for the spring. We can bring folks in like we did, have done in the past, scientists, translational, and it can be an intellectual curiosity, but it also can be, if you want to think about a trial design that may be informed by this as well. So last call. All right. Thank you. I want to thank all of you for being here. Those of you online, let's try to come in person. Thank you for being online on a Saturday, but especially all of you who are here and who came. Thank you.
Trust the movement, I negate the chaos, uplift the negative. I'll show up at the table again and again and again. I'll close my mouth and learn to listen. Whoa, whoa, oh, oh. Whoa, whoa, oh, oh. Whoa, whoa, oh, oh. Whoa, whoa, oh, oh. Whoa, whoa, oh. These times are poignant, the winds have shifted. It's all we can do to stay uplifted. Pipelines through backyards, wolves howling out fronts. Yeah, I got my crew, but truth is what I want. Realigned and on point, power to the peaceful, prayers to the waters, women at the center, all vessels open to give and receive. Let's see the system brought down to its knees. Whoa, whoa, oh, oh. Whoa, whoa, oh, oh. Whoa, whoa, oh, oh. Ooh, ooh, ooh. Whoa, whoa, oh, oh. Whoa, whoa, oh, oh. that I'm a speck of dust and this world was made for me. So let's go and try our luck. Say, I've got my roots down, 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 down deep. I've got my roots down, 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 down deep. I've got my roots down, down, down deep. I've got my roots down, down, down deep. So what are we doing here? What has been done? What are you gonna do about it when the world comes undone? My voice feels tiny, and I'm sure so does yours. Put us all together, make a mighty I am resilient. I trust the movement. I negate the chaos, uplift the negative. I'll show up at the table again and again and again. I'll close my mouth and learn to live.